Hello.
We are live on YouTube. Now I am starting the recording part. So ready to go. So this is Ranjit Sahu, Marketing Head of Walter Bushnell. Welcome you all to this beautiful webinar on population stabilization. Public Awareness Committee AMOX, Family Welfare Committee AMOX in association with Akluj, Akola, Chandrapur, Jalna, Latur, Osmanabad, Pusat, Solapur and Yavatmal welcome all the delegates as well as esteemed faculties for this beautiful webinar on 9th July Saturday evening. With this, I like to hand over the session to Priya ma'am. Priya Sindhe ma'am, she is MBBS DGO GMC Nagpur, consultant obstetrician and gynecologist at Sindhe Multispecialty Hospital, Bhadravati, Chandrapur. She is Secretary Chandrapur's Obs-Gynae Society. She is ex-lecturer Savangi Medical College, Wardha, and she is an active member of FOXY, executive member of Food and Drugs Medico Surgical Equipment Center. She has many, and she is the founder of Sabda Maitri Group as an NGO. With this, I hand over the session to Priya ma'am to take it forward. Over to you ma'am.
Thank you, Mr. Sachin, for the kind introduction. Namaste and greetings from Coal City, Chandrapur. And on behalf of AMOX, Public Awareness Committee and Family Welfare Committee, AMOX. At the outset, I would like to thank Dr. Monica Umbardhan Madam for giving me this opportunity to coordinate the program on the occasion of World Population Day with very interesting topics and with the star speakers. To start the session, may I request all the delegates and the faculties to join for lamp lighting and the virtual inauguration. Thank you all. Now I would like to introduce and invite the convener of the program, Dr. Monica Madam. Her CV, please. Dr. Monica Madam is a consultant obstetrician and gynecologist at Mangalaya Nursing Home and Atharva Fertility Center. As we all know, she is the chairperson of Public Awareness Committee, AMOX. She is the active member of Solapur OBGY Society and has been held many posts at Solapur IMA and Solapur OBGY. She was the website coordinator for AMOX in the year 1820 and youth coordinator, and she's instrumental in designing the website and SOGS app. I welcome you, ma'am. And now I would like to request you to brief all our delegates about our program. Over to you, Dr. Monica, madam.
Thank you, Dr. Priya, for a very kind words. At the instance, I would like to thank Pardeshi sir for allowing us to conduct this webinar under the aegis of AMOX. And I would like to thank Dr. Komal Chavan ma'am for associating with us for this webinar. We have organized this webinar on the occasion of World Population Day, which was first celebrated on 11th of July 1990 to mark the 5 billion mark. More than 90 countries celebrate to increase the awareness about the need to find solutions and issues regarding growing population. The theme for this year is a resilient world of 8 billion, a world that upholds individual rights and choices, offers infinite possibilities for the people, societies, and shared planet to thrive. The guidelines or standards to uphold human rights are non-discrimination, availability, accessibility, good quality, informed decision-making, privacy, confidentiality, participation, and accountability. We wish to highlight these standards and improve the understanding of the government policies, highlight the vasectomy part of the sterilization, as well as discuss the population trends which are going on in the other various countries. I would like to thank all the faculties and the chairpersons and the societies who have joined in for this webinar. Thank you so much.
Thank you, Dr. Monica, ma'am. Our co-convener is Dr. Komal Chauhan, madam. As we all know, madam is medical director at Chauhan Maternity and Nursing Home. She is the senior consultant, DNB teacher, and unit chief at VN Desai Hospital. She was the chairperson of Oxy Medical Disorder Pregnancy Committee in 2019-22, and presently she is the chairperson AMOX Family Welfare and MTP Committee. She is a member Managing Council MOGS and Joint Secretary ISOPAP Mumbai Chapter. She is Premises Secretary AFG and National Expert for Foxy UNICEF Lakshata Project. Madam has many publications to her credit, and as we all can see, Madam has many awards and prizes since 2014, and every year, on an average, she is having these awards and raising at various heights. I welcome you, ma'am, and I request you to say a few words about the program. Over to you.
Thank you so much, Dr. Priya, for the kind introduction. And it is a great pleasure and honor to be part of this program, and which is specifically a focused program on the occasion of World Population Day. And I think Dr. Monica, public awareness, she has a tremendous energy, and it is always when we talk about population control, because you know India has the second largest population and we are rising more than 8 billion now. So the two things are very important, that is awareness and education. So the awareness committee and the family welfare and MTP educational part of the committee, the both committees of AMOX have collaborated, and you're trying to bring and raise awareness and even know what are the practices which are happening all over, so we all can know, you know, how we are trying our best and learn the government strategies, the newer techniques, the newer contraceptives which are come, the efficacy of everything. So it's very good to know all that, and it's a very well thought about webinar. I thank Dr. Pardesi sir, who has always been rock support and always encouraging all of us wherever we are, and Dr. Sujata Dalvi, Secretary of AMOX, and all the 9 societies. I think Monica has in fact contacted so many societies. You know, I am really happy to associate with all the 9 societies, and it's a great pleasure. We are looking forward for a very great talks by all eminent faculties. Dr. Sneha, dear friend, who is also the chief guest today, along with Dr. Shobha Gudi and Dr. Vandana, they both are the guest of honor. So it is really a great pleasure. And we'll start the webinar, the scientific content, because even I am eagerly waiting to hear. Thank you so much.
Thank you, ma'am. We are privileged to have President AMOX as chief guest. And now I would like to request Dr. Monica, madam, to please introduce and invite our chief guest.
Thank you. We are privileged to have you, sir, at the onset as chief guest for our webinar. We welcome Dr. Rajendra Singh Pardesi, sir. He is currently the president AMOX. He was.
It's okay. It's okay.
Yes,
Okay, Monica.
yes. So can you please bless this webinar with your kind words, sir?
Good evening, everybody. Respected Dr. Mandakini Meg, respected Dr. Sujata Dalvi, our Foxy.
Sir, your voice is not very clear.
Dr. Shobha Gudi, Dr. Sneha Boyar. First, I wish to congratulate our ever active chairpersons, Dr. Monica Vardhan and Dr. Komal Chauhan, for organizing such an academic webinar on population stabilization. This webinar will be addressed by eminent faculty, Dr. Shobha Madam, Dr. Vandana Gandhi, Dr. Belkar, Dr. Ajay Mane, and chairpersons. I wish to congratulate websites Chandrapur, Jalna, Latur, Usmanabad, Pusad, Solapur, Yavat for their participation. I wish every success to this webinar. Thank you. Thank you so much. Thank you. Over
Thank
to
you so much
Monica.
for the kind words, sir.
To introduce our second chief guest, I would like to say Dr. Komal Chauhan Madam to do the honors.
With a great pleasure, I would like to introduce my dear friend and a colleague, Dr. Sneha Buyar. The Sneha we have seen, she is really very active from Yavatmal and chairing the Foxy Breast Committee. And I think the superb work she has made the breast committee really a vibrant committee with her hard work. And she is at present the managing director of Sukakarta Hospital at Yavatmal and having a 29 years of experience in the field of teaching and practice at Yavatmal, and she has won prestigious lot of prizes. You know, she is working outstanding work in the rural India, Anandi Pai Joshi Award, Foxy Appreciation Award, and Champions of Foxy, and a lot of so many awards. The list is really endless. And currently, she's also the chairperson. This is really close to both of us because she is the chairperson now as a medical disorder committee of AMOGS, wherein I am the Foxy chair of medical disorders. So we still have to work and be associated, Sneha, again and again. So I welcome you all, and please address our August audience.
Yes, thank you so much. Thank you, Komal. Thank you for your kind introduction. So I would just thank all of you, respected President AMOGS, Dr. Pardesi, Madam Sujata Darvi, all the esteemed chief guests and respected senior Madam Mandakini Meg, Dr. Shobha Gudi, today's program organizers, Dr. Monica and dear friend Dr. Komal, all the esteemed speakers, Dr. Ajay Mane, Dr. Mandakini Meg, Dr. Vandana Gandhi, Dr. Belkar, and all the esteemed chairpersons, all the presidents and secretaries of the societies, Akola, Amravati, Yavatmal, Kusat, Solapur, Akruz, and all the societies. I hope I have not left anyone, Latur, Jalna. So everybody, all of you, I'm so thankful to all of you. And I congratulate the organizers for taking up this very important subject. I'm sure as a postgraduate, we used to always listen to, we India, having a high steady growth of population. And we always wanted to have population stabilization. And for that, China has taken single family norm. And I'm sure all of you must be witnessing these practices nowadays, even our educated mob now going for a single family norm. And I'm so happy to share that even the government of India, Ministry of Family and Health has shared with us that we have now reached to our total fertility rate of 2. And both the family welfare chairperson, AMOGS and Foxy are here to update us. So we are really happy to have this, reach this level. So once again, I congratulate all the organizers, and I wish all the very success to the program. Thank you so much for having me here.
Thank you so much, Dr. Snehal Madam, for sparing your time and for your blessings. Or Mr. Yadav, please mute other persons. Now, I would like to request Dr. Monica Madam to please introduce our next chief guest, Dr. Vidya Tirandra Ma'am.
I am highly privileged to introduce Dr. Vidya because she has been an undergraduate student of the same college, being a postgraduate student of the same college, and now is at the helm of the department. She has presented many papers in state and national conferences and has many publications to her credit. She is instrumental for the upgradation of the labor room and operation theatre under Lakshya Manyata. She was also instrumental in setting up the unique ID numbers for tracking the population and female child abortions in civil hospital, and the MMC was pioneer in this project under her leadership. We are extremely delighted to welcome you, ma'am. Please offer blessings to this webinar. Ma'am, please unmute and speak.
Hello, am I audible?
Yes, ma'am.
Yes,
Yes,
ma'am.
you're audible, ma'am.
Yes. Good evening. Thank you, Monica, for your kind words, for inviting me as a chief guest for this very focused topic of population stabilization. As I am coming from a government setup, I would just like to brief all that India accounts for almost 2.4% of the world's surface area, and yet it supports more than 17.5% of the world's population. Now, the government has made a national policy, and this was implemented in May 2000. And this comes under the name of Janasankhya Sthirtha Kosh. It is mainly to achieve a population stabilization by 2045. So the few activities under these schemes are the Santushti schemes, where along with the public and private partnership, that is the PPP, where the gynecologists and the vasectomy surgeons will come together and perform sterilizations, where the incentives will be given for conducting at least 10 or more than 10 either sterilizations or vasectomies in 1 month, where the surgeon will get rupees 500 for per case, and the clients will get 600 rupees for sterilization and 1,100 rupees for vasectomy. The second scheme is the Prerna scheme, where the age of marriage has been increased from 18 years of the girl to 19 years, and where if she has a first child after 2 years of marriage, the couple will get 10,000 for a baby boy and 12,000 for a girl. And if she has a second child after 3 years of birth of the first child, and if she is opting for a permanent method of sterilization, in addition to the first, she will get a award of 5,000 rupees for a boy and 7,000 rupees for a girl. So these are the two schemes which the government is running. So this was a brief introduction to be given what the government is doing for the patients and for the doctors. I wish you all a very good population stabilization webinar. I wish a great success. Thank you.
Thank you so much, ma'am, for blessing us. Over to you, Dr. Priya.
We can't see Vidya, madam. We were unable to see, ma'am.
Ma'am, please put on your camera.
Yes, ma'am. Thank you, Dr. Vidya, ma'am, for sparing the time and for giving us blessings.
Thank you.
So, our guest of honor is Dr. Shobha Gudi, madam. I shared the platform with the madam in last September when we conducted at Chandrapur this popular on contraception awareness public forum. To invite our guest of honor, I would like to invite Dr. Komal Chavan, madam.
I invite Dr. Shobha Gudi as a guest of honor, and she has been a dear friend and a co-chairperson also in the FOXY year, and currently she is the chairing the Family Welfare Committee of FOXY. She has also been the president of Bangalore Obstetrics and Gynec Society, professor and HOD at St. Philomena's Hospital, Bangalore, and a postgraduate teacher. I think she is a real academician and really having a scientific focused webinars. I think she has done tremendous work. Awareness of family welfare is gone all over India, and really appreciate all the good work you are doing. And also an assessor at GOI and the Project Lakshya, board member of FPAI, and a peer reviewer of Jogi. So welcome, Dr. Shobha Gudi, and please address our all audience.
Thank you so much, Komal. That was a very kind introduction. And, that is the benefit of having friends in the organizing committee, because they'll always be kind. So thank you so much. And at the outset, a very good evening to all of you. I am very proud to be here. I have always considered AMOGS as a very strong and vibrant federation of societies. And I really compliment all of you for building up this atmosphere on the threshold of World Population Day. So my namaskars to the President, Dr. Pardesi, and the Secretary, Dr. Sujata Dalvi, And my special namaskar to Mandakini Meg ma'am, because I am really inspired by her work in family planning during her younger days, when she has done so much in the public sector. Thank you, ma'am, for standing tall in this field and inspiring so many people like me. Well, Monica and Priya, you people are the young brigade, and you have to take forward whatever we chairpersons have tried to do in this past 3 years. All of us, Komal, Sneha, and me, we battled the pandemic because we faced dire circumstances. We were finding it very hard to perform as chairpersons, but somehow we all made it. And I think we should not talk about it, and you should tell us whether we did okay or not. Because being a chairperson is a huge responsibility, because that one particular field of women's health care we have to do full justice, and we have to bring together 38,000 Foxians who look towards better guidelines for care in that field from the chairpersons. And we are always responsible for taking forward the president's message and the secretary's commitment and the vice president's their messages under whom we work. So today, if I am here, it is at the behest of Dr. Shanta Kumari, our beloved president, and Dr. Madhuri, her friendship and her encouragement, and of course, Dr. Basam Mukherjee. I have always looked up to him as a source of good work, even though he has been younger to me in age, but he preceded me as chairperson of the committee. Now, all of you have spoken about how challenging it is for India to come up with solutions, and you have all given the demographic data. So I do not wish to speak about that. What I just want to give one single message without taking much time is what we can do as logicians in our everyday practice. What we can do is we can ensure the reproductive rights of the woman by making her aware that she can have a very productive life as a mother, as a wife, as a daughter, and as a as a woman in the society, if she has autonomy and control over her reproductive life by deciding how many pregnancies to have, when to have them, and at what intervals to have them. And that fundamental right, it is something that we should enable her for by giving her good choices in contraception, making her aware that she is empowered and there are many safe options available for her. So with that, I think I must conclude, and I wish this webinar all the best. And I am really happy that such wonderful speakers are there along with me. Meg madam is there, Vandana is there, Ajay is there, and I am really happy to be with all of you. And the wonderful societies, the 9 societies. Recently, I conducted a webinar, I think Priya knows. I conducted a Sankalp webinar with all of them, and I had wonderful participation. So it's really a real privilege to be in AMOX today. Thank you so much.
Thank you so much, Dr. Shobha. And I think Mandakini madam has done tremendous work, and she has not done in a younger age. She's still young and she's still inspiring us all. So Meg madam is always there. When we talk about family planning, one name which comes in Foxy or wherever is Mandakini Meg madam.
Thank you all for your blessings. And after getting the blessings from the seniors, now is the time to move towards the scientific session. We are very eager to hear all of our speakers, because contraception is one such field. Still, the knowledge is lagging in the patient. I normally do MTPs more than the this contraception. Acceptance is less, and I do more MTPs in my setup. We have to do work very hard in this field. Our first topic for our first session is changing trends in contraception. And the speaker, as we all know, Dr. Shobha Gudi madam, and the chairpersons are, first is Dr. Anuradha Garad madam. She is president from Osmanabad OBGYN Society and director at Garad Hospital. She has done fellowship in laparoscopy at Bangalore in fellowship in infertility and advanced USG training. Our second chairperson is Dr. Anjali Jamma. She is President Solapur OBGY Society. Her area of interest is in cosmetic gynecology. And as we can see, hers is the first laser gynec center in Solapur. Madam has held different positions at Solapur OBGY Society since year 2014. And she has been invited as faculty for conference as a cosmetic gynecologist. I welcome both Dr. Anuradha Madam and Dr. Anjali Madam to carry forward the sessions. Over to you. I think Dr.
Yeah, already introduced, so you can proceed. Yeah.
Yes, ma'am. Please proceed with your this talk.
Okay. Thank you so much, Anjali, and I think Vandana. Who's that?
Anuradha.
Anuradha. Yeah, of course, Dr. Garad. Dr. Garad and Dr. Jama. Thank you so much for chairing this session. And I will quickly share my screen. And can you all see my screen?
Yes, ma'am.
And am I audible correctly?
Yes, ma'am.
Volume is okay.
Yes.
Thank you so
Yes.
much. So I have already spoken about the organogram under which I work. Let me begin with saying that, and I shall be a little brisk and quick in my presentation because I think I must not exceed time. The changing face of contraception is something to be understood by all of us. It can include, but is not limited to, better performance by providers, and also a behavioral change, which is very much aspired in the community and the society level. They all need to understand better that the evidence of, what is the evidence in gender norms on family planning, how much is the uptake, the sustained use we should keep monitoring, how much is the use happening, the interpersonal communications between the HCPs and the community engagement to build support, the cultural and social determinants of family planning should be understood better. When providers understand the reasons for non-use, discontinuation, myths, misconceptions, definitely the performance of the provider will improve in counseling, address the consumer information, the needs and barriers, and the provider behavior change. So it is not just the client behavior change that we should look forward to. It is we ourselves also, our own thoughts and perceptions about contraception should improve, should change. Provider bias for method preference, for especially the youth and nulliparous. Quite a few of us feel that certain methods, for example, the intrauterine devices, are not suitable for the youth and nulliparous, which is not true. So we should improvise in our attitudes. Health workers in public and private sector, we need to know the differential preferences and acceptability of contraceptive options in the two sectors. And therefore, we must know that in the private sector today, there is a lot many options which we are unaware of, but they are easily available to us for use, and we must prescribe them. Public health and preventive health, it's a different ball game from clinical health. Please remember that. And that is why when we say that, it's easier to treat a woman with AUB, but it is more difficult to prescribe her contraception. And that is because that is preventive health. And we are offering treatment or devices or medicines to women who are essentially well. But when they come with symptoms, it's easier to deal with them. So it is indeed the need of the hour. World's population, what we do know, let us first see what we do know. All of you have spoken about the world's population, expected to reach high billion level, like 9 billion, 10 billion, etc. And India accounts for, all of you have told that it accounts for 17%. And we know that considerable number of pregnancies are unintended. 1/5 of all pregnancies which result in live births are unintended. But at conception, almost 50% are unintended. Half of 1 in 2 pregnancy is actually unplanned. Okay, and it can result in an MTP or an abortion. Just imagine the reproductive wastage of God-given life which is happening around us. If unmet need for contraception is met, then we can avoid. I'm sorry about that. If we can avoid, I'll have to. Just for a moment, I'll have to get up. I'm very sorry. I'm sorry, Priya, about that.
No problem.
And if unmet need for contraception was met, I think you people must have read already this slide that 70% of the unwanted pregnancies can be prevented. And yes, there can be fewer maternal deaths, 90,000 fewer maternal deaths. What we need to understand from this slide is only one fact. Family planning is life-saving. It saves those embryos which are unintended, and it also saves maternal lives from unsafe abortion. So this is a reiteration of what I have spoken already, that inconsistent use of contraception is a leading cause of unintended pregnancy, and we need to improvise on the services for contraception. That goes without saying. So this is something positive that I want to share, and this is as late as NFHS 1920. It is very heartening to know that even in the middle of pandemic, the government has succeeded in conducting the survey, the National Fertility Health Survey, and they have found that there is a 55% increase in the modern contraceptive prevalence rate in the last 28 years. There is a 41% decline in the total fertility rate in the past 20 years. You can see that the fertility rate from 3.4 of a national average has come to 2 in many of the districts. It's only in UP and Bihar, Jharkhand that it still remains around 3 and more. But most of the states, especially the southern states, have achieved it. So that is very heartening. And the MEC criteria is integral to our practice. All of you know that this is the Guru Mantra with which we prescribe contraception. This is the Ready Reckoner chart from the 2015 WHO MEC criteria, which can be downloaded. You can see the dark green, light green, orange and red coloration there, and you know that they are category 1, 2, 3 and 4. And I think to the elite audience, I will not be dwelling on the MEC criteria. I have to speak more about the changing face of contraception. And this stands true today also. This base of the disc, these methods which are there prominently displayed here are available in the most commonly available methods, and these are the superscripts from A to Y, which tell us almost to Z, which tell us that there is further nuancing which has to be done whenever we prescribe contraception depending on MEC criteria. You'll see many places 1C and 1D or 1B or etc. like that, and quickly you have to look up at what B means, and then you can apply it to the patient. So today, very happily, there is an app which is available related to the WHO MEC, and this tool provides comprehensive list of medical conditions as well, or characteristics for which all methods of contraception can be safely recommended. Even EC, the emergency contraception, also features in this, and there is a graphic representation of effectiveness which you can use for counseling. So let us come to the methods which have come into the market as a change. One of them is the implant, the subdermal implant. You all know that, if people are not knowing, I must tell that globally it is a hugely popular method, and 11 million people around the world use it. If 25 million are using COCs, which is amongst the oldest method, 11 million is not a small number for the implant. And most of the developed world looks upon this as a very valid option for the younger generation. It's very easy to introduce, requires some training. It contains etonorgestrel, about 68 milligram, which gets released in very small microgram quantities per day, lasts for 3 years. And then, it's radio opaque, and there's a preloaded applicator. So on the inner side of the non-dominant arm, about 10 centimeter above the medial epicondyle, and on the surface of the triceps. That is where it has to be inserted, and hugely advantageous. It is a long-acting reversible method, effective. It is actually more effective than sterilization. That is something we need to understand. It's 0.05% is the Pearl index, whereas sterilization, essentially we tell them 0.5%. Rapid return to fertility once it is removed, and of course compliance independent, cost effective. Some benefits on the menstrual pattern of the woman in terms of dysmenorrhea, premenstrual syndrome, acne, PID, and especially endometriosis, some benefit. These are the insertion and removal techniques, which I shall not be going into. 1 minute for insertion and 2 minutes for removal can be easily done in the outpatient, but requires some training. What are the contraindications? Few only. especially, like all hormonal contraceptives, all progesterone only hormonal contraceptives, a history of breast cancer and unexplained vaginal bleeding becomes MEC category 3, and quite a few are MEC category 2, where more nuancing is needed, like women who are on certain medications like anticonvulsant, anti-tubercular, and antiretroviral. The same criteria which happens to COCs. These drugs may prevent the contraceptive implant from working effectively, so we need to be more careful. Follow-up is very simple. The woman is asked to feel the device at all times and to report whenever she doesn't feel. Of course, there are some troublesome bleeding incidences which can be done away with counseling because it's not harmful for health. And if it becomes impalpable, then of course, imaging can pick it up and we can remove it under guidance. Special situations like HIV, it is very, very suitable. Even if women are on antiretroviral, it can be provided with MEC category 2. And POXI has also endorsed this method twice, in 2010 and 2019, and looks upon this as a very favorable LARC. This is the wheel I wanted to introduce today, and that is actually not available, but it's available online. It's not freely available for use, but this is an EC wheel, emergency contraception, and depicts all the 3 methods: the copper IUD, levonorgestrel EC, and ulipristal. And we know that where all emergency contraception should be considered, wherever there is the ongoing method is failing. For example, the IUD slips out, or the condom breaks, or the pills are forgotten, or the injection is delayed, etc. And highly effective emergency contraception. And the ulipristal acetate is the new pill which was available in the past 2 years, but very recently they have stopped the marketing of this. But I think shortly it will come back. 30 milligram, 5 days window period after unprotected intercourse, and very effective, more effective than LNG in obese women, and whenever there is a delay. And whenever we prescribe ulipristal acetate, the other hormonal contraception will require a week or 9 days or 2 days interval before we can put them on to regular contraception along with other hormonal contraceptives. So because it is essentially the same receptors that they occupy, and if we start the hormone too early along with the EC pill, then it's possible the EC pill might fail. So this is the MEC criteria for emergency contraception from UK MEC, and you can see that most of the medical parts, the medical methods, the COCs and USPs regime, the LNG and the UPA are category 1 even after and sexual assault or rape. And this is one condition where the copper IUD cannot be used as a emergency contraception. In all other situations, copper IUD happens to be the most efficacious emergency contraceptive. The injectable. Now, injectable is something we have all used for decades now, and in the government it has been very successful in the recent past. It has got several beneficial effects. It reduces the risk of endometrial cancer, also some of the benign diseases, very useful for sicklers, very safe, highly effective. Of course, causes slight interference with the menstruation, can cause irregular spotting and sometimes amenorrhea, but women can tolerate all that with good counseling, and can be safely given in breastfeeding women once in 3 months. And the delay in return to fertility need not be a concern because it always comes back. It doesn't go anywhere. Of course, couples need to be told that it does not protect against STI and HIV, and that is one of the disadvantages. And the effect on bone density, we need to understand it better, that there is some loss, but it can be brought back as soon as the woman discontinues it. The only field where we are unsure is in its use in adolescence, where long-term effect on bone density is not known. The subcutaneous version is the new kid on the block, and it's going to soon become available in the government sector. It's FDA approved. It is 30% lesser dose, only 104 milligram. Hopefully will result in less loss of bone and less side effects, but time has to tell. It's very eco-friendly. It's a uniject system. And the MEC criteria are highly favorable for this LARC, the injectables. You can see the category 1 even includes smokers, even includes women with other diseases. including tuberculosis, etc. Category 2 even includes adequately controlled hypertension and uncomplicated diabetes. So it scores over the oral contraceptive pills in all these situations. One-time injection. Category 3 is hardly anything. Acute thromboembolism, of course, or heart disease currently going on, and category 4 is current breast cancer. Now there is this industry field of COCs, POPs, etc., which has undergone a lot of change in the past 2 decades. And we need to understand that a lot many options are available from 21/7 to 24/4, wherein it was thought that 24/4 will have less hormone withdrawal symptoms, and unnecessary withdrawal bleeding can be reduced by extending the hormone prescription for 24 days instead of 21 days. And we all stand better informed today that 24/4 very, very efficacious in women with the PCOS and with premenstrual tension. These are the two situations where 24/4 are very useful. There are newer estrogens coming in, and newer progesterones also coming in. There is a 4-phase pill coming in. Extended cycle regimes should be looked up to for very careful patient screening, and we can put them on continuous pills for 365 days or 84 days. And especially for women who are heavy bleeders, AUB management, endometriosis management, it is very useful. This is one method which I wish to God would come back into the market. Right now, it has gone out of practice, but when it was available, women used to love it. It contains etonorgestrel and with ethanyl estradiol, and needs to be replaced once in a month. The patches are still not available. RISAG is a method which is indigenously developed in India. It's reversible inhibition of sperm under guidance. Still awaits the phase 3 trial. If at all it becomes available, it will be a breakthrough for male contraception. So what changes are desirable? Foxy Sankalp has strived in the past 3 years to see that there is increased provider commitment towards family planning, enhancing their skill, changing their attitude. And one attitude we have wanted to change is that PPIUCD, the postpartum IUCD, is not a poor woman's option. It is a universal option for all women who have institutional deliveries, and it is actually very scientific tool for birth control. Encouraging the integrated care concept, a facility-based intervention has been amongst our prime duties. Encouraging digital technology to augment our services, like Ask Tanu, the Facebook page with a chatbot robo, the artificial intelligence mediated robo who answers clients' question, is another breakthrough. Offering the expanded basket of choice, including emergency contraception, is our prime duty. And we also have developed specific IEC material which has a specific color coding, and eventually it will become available to every Foxian. This was the report submitted to Sigdar sir from the committee, telling about our work towards implant training, but it still has to kind of make a place in the public sector. And we did make an attempt to train. This is the Ask Tanu platform, and this is the PPIUCD training which we tried for private providers. This is the integrated contraceptive care approach which we tried to propagate. And I'm very happy that in Wardha, there is Dr. Poonam was able to make it happen there, and we made the first integrated clinic was launched there in their department. And actually they did submit some data saying that they did look at the contraception uptake, and they found increase in the number of patients who take up counseling. In 2 years there was a significant increase in utilization of family planning services. You can see the method specific increase as well. Post eye care clinic in 2 years from 197 to 266. You can see Mirena increasing to double and Antara increasing to 4 times, etc. So it was very heartening. Well, an estimated 40% of pregnancies worldwide are unintended, and about 85 million unintended pregnancies happen every year. I will end with this endorsement by the UN Commission on Life-Saving Commodities. Remember, in 2012, UN Commission brought out life-saving commodities for for women and children. And they said that in maternal health, it is oxytocin, misoprostol, magnesium sulfate are life-saving. We all know that. But in reproductive health, mind you, they said that female condom, contraceptive implant, and emergency contraception are life-saving. So this is something we need to understand and change the face of contraception. Family planning alone could bring more benefits to more people at less cost than any other single technology now available to the human race. Pregnancy by choice doubles the joy surely and is an ultimate celebration of parenthood. Thank you so much for the time given to me. Thanks a lot.
Thank you, Shobha madam, for your elaborative talk. You have very well explained implants, 24/24, 360 days contraception, patches, female condoms, and explain in depth integrated clinics and family planning services. Thank you very much. Thank you for giving me the opportunity to chair the session. Organizers and
Thank you, Dr. Anjali madam. It's always a treat to hear you, Shobha ma'am. And like different saris and jewelries which females are fond of, thanks to technology, we have huge basket of contraception. And hope with the counseling, our patient will accept with time, because we have a huge this basket, but somehow patients are reluctant still to use the different contraception. So I think counseling is the key to towards the acceptance of this. Thank you very much, Shubha ma'am. Our next session is population stabilization in government policies, and our speaker is none other than Dr. Mandakini Meg madam, and the chairpersons are Dr. Manjusha madam from Pusat. She is the president Pusat OBGY Society for this year 22-23. She is past secretary and vice president Pusat OBGY Society, vice president Pusat Doctor Association, and practicing since 22 years. I welcome you, ma'am. And our second chairperson is Dr. Priya Kadam. She is president Akluj OBGY Society and honorable secretary Akluj OBGY Society in the year 2022. She was the chairperson Women Wing IMA Akluj and lead assessor for Laksha Manyata Foxy initiative, and she has special interest in laparoscopy and infertility. I welcome you, Dr. Priya ma'am, and for further proceedings, over to you.
Good evening all. I'm highly privileged to introduce Dr. Mandakini Meg madam. Madam does not need any introduction, but still we will have to follow the protocol. Dr. Mandakini Meg madam, MD, DGO, FIC MCH, FIC MU, and FIC OG. She was the chairperson ICOG Foxy 2020-21. She is the international vice president MWIA Central Asia. She is a vice president AMWI Central Council. She was national vice president Foxy during 2012-13. She is a past president of Indian Federation of Ultrasound in Medicine and Biology. She was a past dean of Indian College of Medical Ultrasound and was a chairperson of Imaging Science Committee Foxy during January 2006 to January 2009. She is an executive member of Mumbai Obstetric and Gynecological Society since last 25 years. She is a member of FIGO Committee on Infections During Pregnancy. She is a deputy director of health services and handling many important departments like NRHM, RCH, and family welfare. She has a unique distinction of being the only gynecologist to be advisor of Government of Maharashtra on RCH and family welfare. She has worked very closely with Additional Chief Secretary RCH and advised health policy. I'm extremely delighted to welcome you, ma'am. You can proceed.
Am I audible?
Yes, ma'am.
Yeah. So good evening to everyone. And at the outset, I'd like to thank MOG. One minute. This is wrong. एक minute, मला परत उघडावं लागेल. I have kept it open. I have kept it open where it has gone. 1 minute, please bear with me.
It's nice to with all the president and secretaries of different societies. We are with phone calls since last 2 to 3 months, I think.
Please,
It's nice to see you.
carry on. I'm searching my presentation. It was open here.
Okay, ma'am.
Just now. Please give me some time. कारण इथे ओपन होतं. I don't know. एकदम ओपन ठेवलं होतं. I don't know. It has just disappeared.
Hello, Priya.
Hello, ma'am.
Nice to see you.
Yes, ma'am.
In action, in action. And Monica always in action, very vibrant.
Monica, ma'am, only trap me here.
Yes.
Monica and Komal, ever active chairpersons. Sneha.
Thank you, sir.
मी काय म्हटलं 1 minute.
They're all under your guidance.
मी काय म्हणते, can you carry on with the other?
You are all pillars of AMOX.
Manjusha, can you carry on with other lecture? कारण मला ना ते एकदम suddenly it has gone somewhere.
मंदाकिनी मॅम, सचिन हियर फ्रॉम वॉटर बुस्टर. काय इश्यू प्रॉब्लेम काय येतो मॅम?
नाही, मी ओपन ठेवलं होतं आणि सडनली इट वॉज ओपन ओनली. गॉट इट.
येस मॅम.
हा, मिळालं. आता काय करू याला?
मॅम शेअर स्क्रीन करा, दिसत
नाही आलं लक्षात, पण नाही ओपन आहे बट देन नाउ आय हॅव टू. एक सेकंड जरा.
सचिन मॅडम ना को-होस्ट करा ना त्यांचं पीपीटी शेअर करायला.
मॅडम, यू मिनिमाइज इट नाउ अँड देन ओपन झूम.
तेच करते. अगदी ओपन ठेवलं होतं मी याला.
सचिन मॅडम ना को-होस्ट करा, कारण त्याच्याशिवाय त्यांना शेअर करता येणार नाही.
मी केलंय, माझं रेडीच होतं.
मॅम ऑलरेडी शेअर करण्यासाठी ऑप्शन आहे मॅम आमच्यासाठी. मॅम आय रिक्वेस्ट यू, तुम्ही याला स्लाइड क्लोज करा. सगळ्या जे स्लाइड शो करायचे त्याला फक्त ओपन ठेवा, त्यालाही मिनिमाइज करा. येस मॅम. मंदाकिनी मॅम, नाउ इट इज विजिबल.
व्हेरी गुड.
Now ma'am, it is visible. You can go ahead, ma'am.
Sorry. So at the outset, I'd like to thank Dr. Pardesi, AMOX President, our dear President, and Monica for this wonderful webinar. And I think every year AMOX is taking a great lead into the population stabilization programs. And all the co-chairpersons and conveners, my friend Dr. Sneha Buyar, all the chief guests here, and Shobha Gudi, and all the speakers. It's a great evening, pleasurable. And now I'd like to start my presentation. So on this World Population Day, on the eve of the World Population Day, we should make a wish on the World Population Day to enjoy the future that is less crowded. Monica has already said that the theme of the Population Day is the resilient world of 8 billions, a world that affords individual rights and choices, offer infinite possibilities for the people, society, and our sharing planet to thrive and prosper. The theme appears to be very, very interesting, and also very, very, up to the today's highest number of population. So with this theme, I go ahead and I would like to mention here a great work has already been done since last 2-3 years with AMOX and also with the FOXY ICOG also. Recently, I think Shobha knows that we had held the 13, 14, 15 April, we had the full diploma program certificate course on the this contraception and family welfare. Also, last year we did lot of population stabilization program. So here really I will congratulate Dr. Nandita Pashatkar and now Dr. Pardesi, who has encouraged us to go ahead and do the program with ICOG, AMOX, and so many organizations. So with this warming, I will start that population stabilization is the need of the hour. I wish to recollect that what our Prime Minister is insisting, that there is one issue I want to highlight today, that is population explosion. Can we do justice to the aspirant of our children? There is a need to have a greater discussion and awareness of the population explosion. And Honorable Prime Minister has said in his speech on the Independence Day on 15th August 2019. It is so much, focused, and it was his first very, very highlighted speech. So friends, what are the effects of the population stabilization? I did not tell you. I think all our esteemed panelists, everybody and all the delegates know that how we are, because of the high population, how living standards are dropping, rise in the crime and violence, high level of unemployment, thousands go hungry due to the poverty and lack of food. Also, poor health. Most important is poor health, poor sanitation. Shobha has, in her lucid talk just now, said 84 million unintended pregnancy, out of which 50% is a reproductive wastage. So much of the wastage is already is on the card because of this poor health and poor sanitation, environmental degradation, deforestation, and dissolution of family, more divorces, separation, suicide. So all these are the ill effects of the population stabilization, and we have to all worry about this population explosion. Now I'm going to describe this my lecture into 3-4 important parts so that you can carry home message is very loud and clear. I'm going to describe the government and UNFPA. We are doing a lot of work with the UNFPA because on the population stabilization front. Then we have government policies to bring down the TFR. Our all previous speakers and chief guests has already mentioned that we are very fortunate to have TFR stabilized at the 2. And we are really, in spite of our COVID 2 years almost in the lockdown, we could actually do the justice to bring the TFR down. Then the national population policies, which are very, very important. Then various schemes to reduce the maternal mortality, infant mortality, adolescent health. There are many policies where all policies are converging into the, reducing the population. Then what is the financial assistance? Our chief guest, one of the chief, Dr. Vidya, has said how Jansankhya Kosh is, helping us to stabilize this program and also giving a lot of financial help, and also government and NGOs. So these are the few of the subheads which I'm going to describe. Population, it has come to 9 billion now. And I'm not going to go into the demographic details, but what exactly our UNFPA is doing is international statement of the UNFPA. This United Nations Fund for Population Activities. I remember Dr. Sandhya Desai, when she became the president of FOXY, she took me to the UNFPA office and she told me, Mandakini, her theme of the year was population stabilization. We did a lot of work in the population stabilization. I met the chief of the UNFPA and he gave us such a beautiful, agenda for us as an NGO, FOXY, EMOX to undertake. And they say, you bring all the specialists into the main fold so that we all can work together. So that was a great year. So UNFPA, what exactly? It is an international agency which promotes the right of every woman, man, child, as just now told by Monica, that it should be a collaborative efforts for everyone. Also, it creates policy and program to reduce the poverty. It ensures that every pregnancy is wanted. There should not be any unwanted pregnancy, abortion, unintended, birth. Every birth is safe and free from the HIV/AIDS, and every girl and woman is treated with dignity and respect. This is all the time agenda of the government, and the UNFPA is helping us. So UNFPA is assisting government needs since 1974. And I'm really, really proud to say and privileged to say that I have worked very closely as with the UNFPA, because we had Dr. Dev posted as a program head in the Maharashtra, and I have worked very closely as a joint director, family welfare. So, the UNFPA supports research, advocacy, government policy and program. So government always needs these international agencies, to implement the programs. Then UNFPA, with the partnership with the government, also gives the foundations in private sector to raise awareness, mobilize support, resources. It contributes governments in private sector and gives around, the 848 millions And this grant is given very, very generously to the Southeast Asia and all the countries where the population is small. Now, the population policies, how the population policies are made, and also what they address. So they address the unmet need of contraception. I'm not going to talk. Shobha has talked in very, very details, also giving the latest of the contraception. And she has said a very important thing, that contraception and all the contraceptive these things supplies are the life saving. It's not only just a contraception, it is life saving. That is very important. Then health infrastructure, health personnel provided integrated service of delivery for the basic contraceptive as this reproductive and child health. So these are the population policies which are based around on all these principles which I have mentioned. Now, what is the importance? Why should we make the policy? Why should we make the population policy? It is to the population policy largely to determine the future of demographic development of human societies. We are all the time having graphs showing, the development, last 20 years demographic graphs. So this is to determine our future. On that basis, other policies will be there, education policies, health policies, etc. The acquisition of public goods in the degree which objective reduce the poverty, inequality, for that this policy is very, very important. Now, most importantly, what population policy India has, that every state will have a small family norm. I think just now Komal has said that one child norm is already being initiated in urban India. Small family norm by offering in the text. If you remember, all the this Panchayat Samiti, Sarpanch, all the elections, they have to declare that how many children they have. And after declaring the children, then only they are eligible to contest for the various posts, even in the politics. So it is offering incentive in taxes, employment, education, and people who keep the family limited to 2 children. So they are given incentives. Suppose somebody in the family has died, so the one person is given if their family norms are correct. So these are the very good policies which I think will benefit and motivate the people to have a small family norm. Now the fertility trends. Recently, everybody said how we have reduced the TFR because of the last 40 years of continuous policies. At some time, forcible contraception was there. Sometimes there was target oriented. Now we are target less, but we are still oriented. So on and so forth. The policy kept on changing, and I am very fortunate. This last 30 years, I am continuously seeing this policy and implementing it, and I can myself see the change, a very sea change, that now we are really stabilizing our population. So the key thing is to do that, reduce population growth, actually improve the health. Now the reproductive health population and the strategies of gender equality, because gender equality is so important for the population stabilization. And here again the UNFPA comes in the picture, because the male-female ratio, they have done extensive work with the government, the male-female ratio, and delivering the sexual and reproductive health throughout the life cycle of women, like family planning and family welfare, antenatal safe deliveries, postnatal, prevention, appropriate treatment of infertility also. It's not only delivery and ligation and contraception. No, they take care of the, the couple which is, having this infertility, prevention of abortions, treatment of RTI, STI, AIDS, and violence against women. That is also very important. I deal a lot of cases of violence against women and referral also. I think so it is a total plan. It's not only one-sided that only stop the delivering the children. No, it's infertility and so many. And also they have a very major role in the adolescent health. We have done lots of work with them in the adolescent health. And there are all over Bihar, Madhya Pradesh, Maharashtra, all headquarters I have visited. And Maharashtra is a big headquarter of the UNFPA. Now you can see the decadal change in the population. You can see here by 31 we will be by 8.4%, and by 21 we are 12.6%. So the United Nations Funds has released the State of Population report all the time, all 11th July. Every year they release population report, which is very, very important. I am having all the issues of population stabilization in a hardcore copies come. And it is now that against my will, defying the practice, harm the women and girls. Why I'm mentioning here, though the theme is different, but this is again very important theme, because last year they have mentioned that female genital mutilation, extreme bias against daughters, and child marriages, which still we are facing in our Indian context, child marriages and female genital mutilation in other parts. So and also we remember that missing girls, missing females and women, and this phrase was coined by Amrita Sen, that the missing female and women. And I remember our ex-chief secretary was there, who used to bring a big UNFP report, and there were red marks in the Punjab, Kolhapur, other places. And I used to ask, what is this, sir? He used to say, red. And then I realized that how census is evolving with the giving a lot of red, then orange, and then green. And hardly there was in the Kerala only there was green, otherwise everywhere it was red and orange. And from the red and orange, now we have come a long way since 1990. So this was a big book. I think many of you must be having this kind of book, and it has given a real picture of the girl male-female ratio. That is how government has become very strict with the PC, PNDT and other things. So now this is the highest rate of excess female death was there, and this was the data. So female genital mutilation, removal of the external female genitalia, and this was estimated that 4.1 million girls will be subjected to female genital. So UNFPA has taken a great lead, even in many communities in India also. I don't want to mention the name, but they still practice the female genital mutilation. Then now the second is a son preference. I should not say about it because we all know, I don't want to take time, but gender bias sex selection and advent of technology has really gone against the female fetuses. Then I come to the child marriages. Though now the age is increased from 18 to 21, and also our chief guest is from 18 to 19 also. So in India, the poverty, poor education, and rural-urban divide. So still there is a problem of child marriages. Then reproductive health, population and strategies. So, and as Shobha has mentioned very correctly, in spite of COVID, where we worked last 2 years as ICUG chair and their committee, still we could stabilize the population. There was extensive use of newer contraceptives, and people were very much aware of the contraceptive, and in that period also we could bring our TFR down. Now the policies for educating the girls. By educating the girls, you are giving her the chance to do, get the job, women empowerment, girl empowerment, and that is how reducing the fertility. That is what is. And there are various schemes. My, later on speaker is going to talk about those schemes, so I am not going to talk. And this is a very important policy which government has taken, that, increasing the age of marriage from 18 to 20 is a very important step. So key messages in this particular segment is we have to respect the women, we have to protect the women, and also we have to empower the women. And these all harmful practices has to be stopped. Now I come to the third part, that is the Niti Aayog, which has been formed. The Niti Aayog said that now Government of India says that roadmap for the population stabilization should be there on the, and also very big increase in the basket of contraception is the main policy now, though it is since last so many years, but now again repeated that increase. I think Shobha has given details about the latest contraception, which are going to be included into the mainstream of the government supply also. And this is again that, unintended pregnancy. I don't want to repeat this. So key recommendation in this segment will be, we have to focus on the adolescent youth. There should be interdepartmental education, health, all these convergence should be there. Demand generation and excess of contraception use excess should be there. And now the Arogya key recommendation will be treating the population stabilization as a national priority. My next speaker is going to talk on this national population policy, which I will not talk. Only thing is, what I want to tell you is that because I just checked this, how the policies are made. So we are very progressive nature. 1951, we started making the population policy, and that time there was a British government just before, and they never bothered about actually population stability. They wanted more labor force. So, reducing the birth rate was only extent necessary to stabilize the population. But later on, it has become 21.5% from 51 to 61. But later on in the government, we started taking the small family norm, then control, and there was target oriented, which I was talking. We have worked extensively in this this family planning program. Dr. Asha Nikhil, many people are there. When we used to do 200, 300 in the camps, and there was target approach. But because of there was a lot of criticism of this target approach, and now that has come the quality approach in the reproductive and child health. So this is a population policy. I think my next speaker will say, very important is that now a motivation of the doctor giving the vasectomy, which our chief guest has said, and also the intensive this thing for even for the female plus. At our time, we used to get 10 rupees for doing a sterilization, but now they are offering 500 rupees, and also for the vasectomy. So these are the things which are there. And now the Jansankhya Kosh, which giving the financial assistance to the national population stabilization, and also the improving the intersectoral coordination, and aims and objective is to promote and support the schemes and give the innovative ideas to the government. So these are the Jansankhya Kosh Divas. And there are various IEC activities, information, communication, and all these programs are continuously being monitored and done in the government. And I think all the NGOs, FOXY is very much a big part. EMOX is a big part of this government program. They are collaborating with the, so mini laparotomy, then sterilization, vasectomy, and ASHA workers training, and also the ASHA workers are also given a lot of incentive, you can see here. And the last but not the least, the PPIUCD, property IUCD is a very popular method. We are doing that with the governments, and all these are the mainstream of the population policy of the government. So friends, by improving the health and empowering the women, population growth comes down. And also, I attribute this success to Florence Nightingale, because the nursing is a very important component, and they help us in all the contraceptions, and even that tubectomy is also. So I also give a respect to the nursing profession and our other allied branches, which make a part of our medical team. So with this, a great thank you to all of you, and thank you very much for patient listening.
Thank you, Dr. Mandakini Megh ma'am, all-time favorite orator. Very well explained the theme of World Population Day. Very well explained the causes of population exploitation, which is almost 9 millions. Very well explained the government policies for population stabilization, importance of UNFPA, that is United Nations Fund for Population Activities, and population policies to determine our future, on which other policies of the developing country is dependent. UNFPA takes care of all aspects of women and adolescents. It protects, respects, and empowers women, and improve her health, which ultimately is useful to control the population. Main policy is to increase contraceptive basket to control the population. Then also the access of contraception is increased to the young population is very well explained. Also, you have very well explained, ma'am, the Jansankhya Kosh activity and the importance of the ASHA workers for controlling this population. Thank you, ma'am. Thank you.
Thank you very much. Thank you.
Thank you very much, respected Dr. Mandakini madam. And our chairpersons, Dr. Manjusha, and nicely you have done the sum up, Dr. Priya Kadam madam. Thank you very much. Yes.
Thank you, ma'am.
Very attentively you have listened and did a very nice sum up. Thank you very much.
Thank you, ma'am.
It is very rare for this because so many data and figure and democracy. I was not knowing that you are at so much detail you are attending. So thank you very much. Like
Thank you, ma'am.
everybody else is also was listening. They are looking
Yes,
quite attentive.
Yes, ma'am. Thank you.
It was very interesting.
Yeah.
Yes, ma'am. It was
Sir,
interesting.
thank you. For this is thank you very much.
Thank you, sir. Thank you.
1 minute. I want to say one sentence. Dr. Pardesi, आपला एमॉक्स चा खूप मोठा रोल आहे. If you can see that, in the beginning only because we had done a lot of program for the population stabilization with EMOX, and also we have done this family welfare diploma courses also. So I think, heads up to EMOX also, and all our, now Komal is in charge of the family welfare program, Monica is in charge, Rashmi is doing such great work. So I think EMOX is really, going forward and helping the nation and the government in really stabilizing the population through your members. Thank you very much.
You are the guide and spirit of this all. Your work in family planning and contraception.
Thank you. Thank you very much.
So after this changing trends in contraception and government policies, Dr. Vandana Gandhi madam is coming up with the vasectomy, which is always neglected. And for this talk, we have the chairpersons. First is Dr. Kavita Gandhi madam from my own society. Madam is Foxy Executive Member of Adolescent Committee. She is consultant at Gandhi Hospital, Chandrapur. President, Chandrapur Vijaya Society. Foxy Late Assessor to Lakshya Manyata Mission. She is associated with Manav Vikas government projects since 15 years, and she with Pantapradhan Janani Suraksha Yojana. I welcome you, ma'am. Our next chairperson is Dr. Anil Kayande, sir. Sir is president from Jalna, and sir is Registrar Bandra Bhabha Hospital for last 6 months. He is a consultant gynecologist at Deepak Hospital, Jalna. I welcome you, Dr. Anil, sir. And over to the chairpersons. Next CV, please. Yeah. Dr. Kavita Gandhi, madam.
Yeah.
Please introduce our next speaker.
Okay. Good evening, all. It's a coincidence, Gandhi introducing Gandhi. It's an honor to introduce Dr. Vandana Gandhi. She is MD DGO and has done diploma in pelvic endoscopy from Germany. Currently, she is working as endoscopic surgeon, sonologist, and obstetric gynec practice. She is a founder of Female Fetus Protection and Save Girls Counseling Center, Akluz. She is founder of Akluz Society 2013 and president of Akluz 2018-19. She was a member of Contraception and Family Planning Committee, AMOX 2018-20, and has received IMA Maharashtra President's Appreciation Award 2006. Her special interest is in infertility, adolescent anemia, PCOS, and obstetric USG. She has presented her work on anemia to UA Foxy Figo. So here I present to you the talented and dynamic Dr. Vandana Gandhi. Over to you, ma'am.
Thank you. Should I start with the sharing screen?
Yes, ma'am.
Please tell me whether it is visible. Is it the visible presentation?
Yes, madam, it's visible.
Yeah. At the outset, I would like to thank
madam, make it in this which form? Yeah. Yeah, it's
Is
done.
it seen?
Yeah.
Okay. Thank you very much for the organizing committee of AMOGS, that is Public Awareness Committee, as well as Population Family Planning Committee, and all the organizing committees other than these. I'm very happy to choose this topic of vasectomy, which is a neglected one. So, by occasion of this World Population Day on 11th of July, the theme is already declared by all the previous speakers, that a world of 8 billion towards a resilient future for all, harnessing opportunities and ensuring rights and choices for all. So by this occasion, we are today thinking about the population stabilization, and one of the aspects is contraception and sterilization. So today I am talking on this topic of vasectomy, which is always neglected. You all will agree with me that vasectomy is very rarely discussed. Actually, it is a very small topic, but we are not considering because it is not highlighted as a procedure by patients, by society, and so we doctors are little bit not taking initiative. That is the fact. The World Population Day on 11th of July is a holiday that's dedicated to focusing on the importance of population issues. So on this day, I think that the neglected topic of vasectomy should be highlighted and the importance should be discussed. This day was established by the United Nations as a result of massive interest of the people had in 5 billion day in 1987. We will consider these points during this talk. That a short review of definition and purpose of this surgery of vasectomy, the anatomical understanding so that we can know the benefits, social scenario and statistics, which is the current strategy and the facts, medico-social aspects about vasectomy, that is the myths and how to correct them. And I would suggest a few protocols to highlight this neglected topic. Harrison of London performed the first human vasectomy. We'll go in brief of the history of vasectomy, but it was not for sterilization purposes, but to bring about atrophy of the prostate. During the Second World War, vasectomy was finally regarded as a method of birth control, but the first vasectomy program on a national scale was launched in 1954 in India. So we are 68 years plus the first launching. The first recorded vasectomy was performed on a dog in 1823 by Sir Cooper from England. A short time after that, Harrison of London, who was a barber by profession, performed the first human vasectomy in 1924. And the first vasectomy program in India was in 1954. The definition and purpose: it is a surgical procedure for male sterilization and a method of permanent birth control. During the procedure, the vas deferens of a man are tied and separated to prevent the sperms from entering into the seminal stream. We know the anatomy that the vas deferens starts from the epididymis through the scrotum, traverses through the inguinal canal behind the bladder, joins the seminal vesicles, and again joins the prostatic urethra, and then continues as a urethra. And through this vas deferens, the ejaculate delivers the sperm. So to prevent the sperm entry, we have to cut this vas deferens, as we similarly cut the tubal ligation procedure, the fallopian tubes. The beauty of this procedure is that this vas deferens is just below the scrotal skin, and we know fallopian tubes are inside the abdomen. We will shortly come to the anatomical and practical benefits compared to the tubal ligation. Here in the picture, we can see the tubal ligation and vas deferens. Fallopian tubes are intra-abdominal, whereas vas deferens is under the skin. It is very much superficial for the easy surgical access, and there is no risk of visceral injury. The tubal ligation needs either spinal or short general anesthesia or local and sedation. So there is a need of anesthetist to avoid any discomfort to the patient. Whereas in vasectomy, it is done by a small nick under local anesthesia. Now the newer NSV technique avoids any stitch or any cutting, and so there is minimal pain, and the tubectomy needs a stitch because we open the layers of abdomen. The surgical time is less in vasectomy as compared to tubal ligation. Complications are rare and minimal and easily manageable. The increasing incidence of cesarean section increases the potential risk of adhesions and bowel injury. So tubectomy is always on higher risk side, but there is no such risk involved as abdomen is not opened in vasectomy. The points to review that after anatomical understandings, we should know what is the social scenario. If it is the so much easy and less complicated procedure, then are we happy with the statistics? Let us see. Why not it is a preferred method of sterilization? And why it is a neglected method? The social unawareness of benefits and the medico-social unawareness. This point, I would like to highlight that socially in our Indian scenario, we are standing on ignorance, illiteracy, and unawareness. In addition to that, there are blind faiths and wrong myths. So this social unawareness has neglected the vasectomy. There is also medico-social unawareness, and we as doctors have failed to increase this awareness. There are wrong myths about vasectomy, such as there is difficulty for sexual act post-operatively, or there may be impotence, or cannot do heavy work and field work, etc. So usually men avoid to accept the vasectomy procedure. There is a patriarchal mindset in India, which we know, that usually the pregnancy, delivery, feeding, that is breastfeeding, and childbearing, these four important things are born naturally by women. Automatically and conveniently, the next things to avoid further pregnancy have purposefully shifted to her. So I think this is a clever rescue thought by men and this patriarchal mindset, which has again kept the vasectomy procedures to a very low level. There is misunderstanding of the family planning concept. There is a convenient meaning drawn as if it is a motherhood planning, and hence the responsibility goes to the mother, that is women, and whole and soul, the family planning, contraception, as well as sterilization, everything is taken granted that it is a responsibility of woman. So I would like to say that हे स्त्रियांचे नियोजन नाही तर हे कुटुंबाचं नियोजन आहे. दॅट इज द मिनिंग ऑफ फॅमिली प्लॅनिंग, बिकॉज कुटुंब म्हणजे स्त्री आणि पुरुष दोघही, बट दिस फॅक्ट इज कन्व्हिनियंटली निग्लेक्टेड बाय अवर सोसायटी. My next slide is the false myths about vasectomy. Vasectomy protects against sexually transmitted diseases and including infection with the human immunodeficiency virus. This myth we have to clear because we are the medical persons. During counseling, we can clear this point. As well as there is a myth that vasectomy will make a man impotent and reduces his sexual drive. This is also an relevant point, which is the main important point, and male acceptance towards vasectomy is very low. So it is our duty during counseling to highlight these 2 points. There is also additional a manly ego. So the doctor's counseling versus wife's counseling. I can quote an example. Whenever I have tried to counsel to a couple who comes for contraception or either sterilization, I share my experience. Imagine the drama in my OPD. The couple comes inside and we discuss about the contraceptive methods or sterilization. Husbands are totally on mute mode. Wives are thinking. There is no reply after my counseling and no decision. Then after a quiescent, silent period, there is a waiting for a while, and then wife utters, "Do my tubectomy only." All counseling becomes futile and my tubectomy register list was updated once more. So this is a common story. And every time I have tried to counsel the couple, the next time I don't see the husband accompanying the patient because I may again talk about vasectomy. So this is a very common scenario. If we see the statistics, here in the first graph, we see the red indicated is a male sterilization. In India, it is less than 2.5%, whereas in Brazil and China, it is less than 5%, whereas in USA, it is comparatively 50% to tubal ligations. And in United Kingdom, the male sterilizations are almost double the female sterilizations. So in United Kingdom, what they have done, we should study. The second picture shows the awareness percentage. In Indian scenario, the Hindu population is found to have 87.2% awareness, whereas the rest of population of Muslims, Christians, and others are less than 3 to 12%. So the awareness part is very poor. And even if awareness is there, acceptance part is still poor. So as main fear for vasectomy, the onus of family planning falls on Indian women. The latest news of 30th April 2022, India's latest health data shows that nearly 38% of women have undergone sterilization, but only 0.3% of men have had vasectomies. These figures itself show us that this is a neglected part. The prevalence and acceptance of vasectomy in India has fallen from 74.2% in 1970 to 4.2% in 1992. The barriers in the organizational structure and poor access to services may contribute to the decrease in vasectomies. The next years, that is between 2017 and 18, 93.1% of sterilizations performed in India were on women, whereas only 6.8% were men who underwent vasectomy. It stated another report by National Health Mission, a family planning initiative by Government of India. And the recent figure we just saw that 38% of tubectomies and only 0.3% of the vasectomies. So these are very depressing figures as seen the comparative study. My local area statistics, by curiosity, I just ran to the DHO and took these small statistics from them for the last 4 years, that how many vasectomies are performed each year in my district. They gave me the figures of rural Solapur, that in year 2018-19, the tubal ligations were 17,348, whereas vasectomies were merely 4, and the target was 20,085. In 2019-20, then when the COVID lockdown started, the target was not updated, but there were 16,482 tubectomies, whereas only 11 vasectomies. In 2020-21, there were 8,156, whereas 4 vasectomies. And 2021 and 22 means the current year, they have taken financial year April to March 22. There were 12,319 tubectomies, whereas only 12 vasectomies. We see that this comparison shows us that tubectomies are in thousands or 5 figures, and vasectomies are just in counted on fingers. So these are very poor statistics showing that the program of vasectomies has been almost gone to the corner. There may not be any efforts other than some government camps, but overall there are very less efforts and less policies to emphasize the importance of vasectomy, which is very beneficial to the patient as compared to the tubal ligation, considering the surgical aspect. Can you give me a second? I'm getting this line in between. So this shows the failure. Some amazing statistics which I found, that I just talked to DHO, he told me that in underdeveloped districts of Maharashtra, like Adivasi area, Nandurbar, Yavatmal, Gundia, Bhandara, and Gadchiroli, the acceptance of vasectomy was tremendously high. Tubectomies versus vasectomy ratio was 60-40. Sorry, I have just written it reverse way. Tubectomies were 40 and vasectomies were 60. I just wrote the figures in reverse way. So tubectomy to vasectomy were 40-60, means vasectomies were more. And why this has happened? So the doctor who gave me this feedback, that in these underdeveloped countries, the education percentage were very less, underdeveloped districts of Maharashtra, and these people have high acceptance because they don't have too many myths and misunderstandings. Whereas in educated part of other districts of Maharashtra, only 99% are tubectomies and less than 1% even vasectomies we have just seen. So those educated people can understand better the counseling, but they are least interested. And those uneducated people who are Adivasi area people are accepting these surgeries. So this is amazing, interesting, and depressing too. The suggested protocols include counseling and following recommendations for counseling of the patients about vasectomy. These may help to minimize the risk of litigations, as well as these may help to increase the percentage of acceptance, so that family physicians who provide vasectomy or the surgeons or urologists should consider the following points. They should conduct a personal consultation with the patient using audiovisuals. They should discuss the impact of vasectomy on sexual function and remove the wrong myths. They should explain the procedure using diagrams, videos during the office visit for the physical examination. They can explain possible minor complications and risks, including the possibility of failure. They can explain the need for the post-operative semen analysis after 8 weeks and after 6 months, and the need to use another contraceptive method for 2 months at least after vasectomy, till the report of semen analysis comes nil. They should emphasize the permanence of the procedure, that it is a permanent method of contraception, and henceforth there is no, he cannot father the child. They have the patients read and sign in an informed consent form. They can provide pre-operative and post-operative instructions and answer questions and respond to the concerns, and make a telephone call to the patient post-operatively the day after surgery, inquire by a fair talk and get the feedback. These are few efforts which may help to take the patient in confidence, to increase the image that vasectomies are done successfully, and no post-operative or very minimal post-operative problems are handled, and vasectomy is not a very big issue. This we should bombard, or we can explain to the community. Some facts: we have to remove the fear and myth during counseling. What to think about before vasectomy? We should tell them that vasectomy is a permanent method of birth control and not easily reversible. Vasectomy is a safe and effective, and it is a daycare procedure requiring hospitalization for few hours only. The performance of vasectomy as an office or clinic procedure, the anesthesia and surgical technique, and post-operative care. So these are very, very small, within a 10 to 15 minutes counseling with videos. I have done it, I'm doing it. We can all adopt this counseling procedure. The patient must also understand that sterility is not immediate, and couples' questions, every question must be answered. The counseling may take the form of movie or booklet or posters and conversation with a trained counselor or the surgeon himself. What to expect after surgery? We can tell the patient he can resume sexual intercourse once the pain and swelling subsides. That is recommended after 1 week. But the partner can get pregnant until the sperm count is documented to be 0. So another method of birth control should be adopted until the patient has sperm count test 6 to 8 weeks after vasectomy or after 10 to 20 ejaculations. Technical ease and post-operative comfort. We have to explain the limit physical activity for 1 to 2 days. Don't shower for 24 hours. We have to observe for any hematoma if at all during the procedure there is a bleeding. The patient should avoid strenuous activity for only 5 to 7 days and avoid sexual activity for next 7 days. So there is a very post-operative, very less period of abstinence as well as limited physical activity. So they can very well cope up after proper explaining. The benefits of vasectomy also need to be counseled. Vasectomy is an excellent method of permanent contraception for the couple whose family is complete, who are mature and fully informed, and who will accept the permanent sterility. It is also valuable in preventing the bacterial epididymitis, and vasectomy is customarily performed in the office or clinic settings under local anesthesia. So these are very practical aspects which patients should know. The complications of vasectomy. The specific complication of vasectomy includes spermatic granulomas of the vas and epididymis, congestive epididymitis, and anti-sperm antibodies. Numerous studies have reported that there are no deleterious effects on patients' general health. Manhood, pleasure, and sensations are unchanged, and the woman needs no longer fear the possibility of an unwanted pregnancy. We can use the counseling methods or modes that video counseling is possible, posters in our OPD, talks in local languages for awareness programs. On many occasions where we are invited as speaker in public, through the Rotary clubs, through the Lions clubs, through the colleges, there we can voluntarily take the topic and explain that this is a very important part of population stabilization and very effective and safe. So these family planning counseling methods should be adopted. If we doctors are convinced about the need and the benefits in concern with the population control and our patients, then we can dream for the NSV to make a popular method. I follow this protocol that if there is a cesarean section and the couple is willing for sterilization, so when it is combined with cesarean section, tubal ligation should be the method of choice. But if there are interval sterilization and the previous vaginal deliveries, then why to open the abdomen? Then we can promote the NSV, which is a very, very small procedure and very safe. So I appeal that we should not wait for government to act. We can initiate vasectomy camps monthly in our private setups. We can plan attractive models for counseling the couple. We can use educational aids and activities through colleges. There are government programs in colleges. Presently, I'm working on anti-sexual harassment committee of agriculture college in my town. So I have seen that these people are interested to do projects, and we can advise them different activities for the young generation to promote these neglected topics. Even I would like that if government can have celebrities, they can use the testimonial or advertising videos. We know that we have seen many times on TVs that celebrities or Bollywood stars shine in the commercials of gutka and pan masala. Then why these cannot be paid for health awareness and making videos and YouTube videos? These all celebrities can work for pan masala. They can very well work, even if they are not themselves vasectomized, they can very well work as a model, and within a 1 or 2 minute video, they can counsel the public in local languages or national language, the awareness aspect of the vasectomy. In short, I will end my presentation with a small video which I use in my OPD. I think it is very well audible.
Voice is low, ma'am.
Is it now okay?
Ma'am, you need to reshare with the audio.
I have made it to full 100%.
But actually, voice has not shared, ma'am. At the so you have to reshare once again. You will get one option when you are sharing, ma'am, with the audio clip.
Vandana, very well we can see now.
Yeah, we can see.
So there is
They have explained, actually it is a very small video.
I think it is very self-explanatory.
Self-explanatory, and it is in English, but what I do during my counseling session in the OPD, I just keep the video on mute mode, means audio on mute mode, and I talk instead of the audio. I talk and show this video, so that because we have to use our local language. They are explaining the surgical aspect, how it is easy. And because it is an animated video, it is very comfortable for the couple and males to listen. There is no pain because skin is locally anesthetized. The doctor opens by NSV method, by a special forceps, brings the vas deferens, ligates or cauterizes. This is the cauterization done. Similar procedure is repeated on second tube. See, this video is self-explanatory, and what I want to emphasize that this is just a 1 minute video. I think I have to stop the sharing. This video is very self-explanatory, a small animated part which we can show in our OPD, and I keep it on mute mode and I speak in local language, so I can explain what they are doing. Being animated video, they don't feel anything to be shy, because we don't show the anatomical parts of a man, because they don't like to see it from a female gynecologist. It is obvious. So I think that with a proper efforts by gynecologists, by surgeons and urologists, we can increase the awareness and we can make this neglected part as a part of national program. And I think it will be a justifying part towards the women also, because they are undergoing, there is an increasing trend of cesarean section. They are at a potential risk of more adhesions, and why they should take the more chance. Even I have told my patient that if you want your name to be written as a father of that child, then it is your responsibility to take one stitch or even NSV without stitch, to have it a complete father of that family and be a part of family planning. म्हणजे नुसतंच नवऱ्यानी वडिलांनी नाव लावणं हा कुटुंबाचा पार्ट नाहीये, त्यांनी त्यासाठी एक टाका घेणं सुद्धा तेवढंच महत्वाचं आहे. सो इन आवर ओन स्टाईल्स वी कॅन कन्व्हिन्स देम, अँड आय थिंक इन नेक्स्ट फ्युचर 10 years we can make the statistics a little bit better for Indian scenario. Thank you for inviting for this talk, and I myself selected this talk actually. And thank you the organizing committees, Monica and Priya Shinde madam, and all our senior dignitaries. And thank you all for patient listening.
I can see that smile on the face of Shobha Gudi madam and respected Mandakini madam. So, kuch hatke talk, and from the first hand information from the madam. Thank you very, very much, madam. Anil Kayande, sir. Few words from you. Are you there, sir?
Thank you.
Yeah.
Yes, thank you. Am I audible?
Yes, yes.
Yes, sir,
Thank
you
you,
are.
Dr. Vandana Gandhi, ma'am. It is very nice, neatly explained vasectomy talk. I think this is the first vasectomy talk in near last 2-3 years. After COVID, during this COVID era, we have a lot of talks, but first was talk on vasectomy issue. NSV is very simple procedure, and it gives best results. But as a gynecologist, we promote in the start of practice for few years. Then, due to not acceptance of the educated peoples, Adivasis are better than educated peoples to explain the things. And henceforward, we private practitioners should try to help government to make a increased count of vasectomy cases. Thank you, Dr. Vandana Gandhi, ma'am.
Thank you.
I want to say something, Priya.
Yes,
I remember, as days of my deputy director, there was a massive increase of the male participation, and the central government has taken up this issue of the male participation. In that, all the gynecologists were, motivated to be trained in the NSVs. There was extra compensation for the male vasectomies, also for the surgeon charges, also for the vasectomy, and lots of importance was given to this male participation in the family welfare program. But what happened is, when all the time in the meeting in the central government, we could see the the percentages. Vandana has said very correctly. This Maharashtra was lagging behind 2.5% like that. And in Mumbai, because of the efforts of previous health, South Bombay, this family welfare person, Dr. Asha Advani was there. And she has intensively, trained the people. And that time, the Mumbai has increased 5% in the male participation. But overall, and what was very surprising was Punjab was heading with the 18% that time, even though Punjab is, so they were heading. So I want to just bring it to the notice of Vandana and everybody that they tried their level best to include the male participation, including the training of gynecologists in the NSV, and there are huge efforts being done. In spite of that, what you have said is very correct. There was male participation was less. Tribal people were very happy to get vasectomized in the many Dharni and the other areas, but the male participation from the urban areas was very poor. So I think this effort should be carrying on, and it's such a good trend that you are showing that video. Please share that video for all of us also, so that and we also will like to show that same video and explain them in their native language wherever we are, and it will be a good start at least for. And we urge the gynecologists to get trained in the this vasectomy NSVs. That will be again a very welcome change as far as the participation of gynecologists in family welfare program. So that is my.
I would like to share one point, madam, because I was convinced very early. I could convince my husband, my brother, and everybody from my family, my sister, brother, have undergone vasectomy with a very good willingness. We women have not taken the scar for it. Because I had normal deliveries and it was my right not to get more stitch.
It is you.
I think, madam, can I also say 30
yeah,
seconds?
Please.
No,
Yeah.
I think we should celebrate Dr. Vandana Gandhi as the family planning champion. We must celebrate her from the committee, madam. And,
I think please.
I'll do that.
In AICOG Kolkata, please take this.
I will do that, because I have been encouraged by Dr. Basap to identify family planning champions across the country, those who are practicing family planning very well. And I think she deserves it. So hats off to your efforts, Dr. Gandhi. And I think I just wanted to share that Family Welfare Committee has collaborated with FPAI for NSV training for male gynecologists. So we thought that in the private sector, if a couple chooses a male gynecologist, then they will feel very comfortable if the male gynecologist does vasectomy for the husband. The same doctor is treating both. So we like that concept, and we have done already the call for action webinar in the month of April. And the first batch, Dr. Kaza, who is the, he is the master trainer for this, and Dr. Gurpreet from Punjab, both of them have agreed to train selected candidates. We are hoping to do the first training session in Kolkata. And we already have 4 trainees identified. The main challenge in any such training I wanted to share with all of you is recruitment of cases. So they need to recruit at least 20 cases for 4 trainees, so that each one of them gets to observe and to do. So that is the problem, but we are trying to do the very first batch this month. I'm just praying to God that it comes through. Thank you so much. Thank you.
Can I have one appeal that through the funds of AMOGs or family planning committees, can we hire a celebrity and make a YouTube video, just a 1-minute video that he is promoting? It may make a very good impact. They can make commercials of gutka, then we can hire them for making a good educational videos about vasectomy.
You can invite.
I also want to share my experience, madam.
You want to? You can invite Saif Ali Khan. He's a perfect candidate.
Yeah.
I think Dr. Manjusha wanted to say
I
something.
want to share my experience, madam. When I was a medical officer in 1997, Bhandara district, there is a percentage of vasectomy is quite good. We used to promote the patient like to me, you can come riding on cycle and you can go like that after doing the vasectomy. It is so easy, and actually the rate of complication, post-operative pain is so less. They used to accept it very much, and the procedure is very easy. There was another medical officer, male medical officer, who used to do that vasectomy, and he taught me in 1-2 cases. It is very easy and very simple to learn. So we all can learn doing vasectomy. I don't know how many person will be ready to do with our hands, but it is very easy procedure, and we can promote this. And I have my brother also who has done vasectomy, and he has no problem at all for that.
Thank you all for all the inputs. Now I'm feeling very much proud that we were discussing about this topic, and this has come out so well. And we have tried to cover from PSM department also, because they are in with the government policy makers. And so our next speaker is from PSM department, and the topic is population replacement recent trend. The chairpersons for the session are Dr. Pooja Padmawar. She is the consultant obstetrician at Preeti Maternity and Surgical Hospital. She is presently the secretary of Yavatmal OBGYN Society. She has special interest in high-risk pregnancy. And second chairperson is, please, Dr. Asha Nikte. She is member of Public Awareness Committee AMOGS Akola branch. Madam was president in 1994 of Akola Society, and she has received Best President Award of BPNI in 2005, Best President of IMA Akola, and she has done certificate course in contraception. I welcome the chairpersons, and over to you. Next CV, please.
Thank you so much, ma'am. Dr. Bedkar, he is associate professor in community medicine at JMC Nagpur. He is having teaching experience of 18 years. Welcome, sir.
Thank you, Pooja, madam. Am I audible now?
Yeah.
Yes, sir.
First of all, I thank all the organizing team and the senior faculty over here. And these people give me an opportunity to talk about the population stabilization along with recent change. So, first of all, I also want to add something about some of the faculty who share the things. First of all, Meg Madam has done tremendous work in the public sector, and also she has shared some of her experience also. She talked about the incentives and tax benefit for the small family norms. She also talked about the gender inequalities and the role of particularly important role here is for gynecologists. I personally feel is the crucial exhibition of MTP as well as PCP and DD Act. Later on, I will also want to thank the work done by the Gandhi Madam. She also want to promote the vasectomy, which is very much accepted in the tribal areas. But we want to again see how much percentage of the vasectomy are really accepted in the much educated people, right? This is, I think, not been accepted in most of the educated person or the people. Shobha Godiman also had contributed a lot for the modern contraceptives that has been used that should be prohibited in the population stabilization approach. Now I begin with my presentation about the population stabilization. So I want to share the screen. One second. It is visible now?
No, sir.
Not yet.
Wait.
सर पीपीटी खाली घेतलाय आणि मग ओपन करत आहे का?
हा, त्याला क्लोज करावं लागेल. एक मिनिट.
हा. Mr. Yogendra, please help, sir. Yes, sir. Yes, sir.
हा, बेलकर सर दिसतंय आता.
Now it is done, ना?
हो सर. सर फक्त फुल स्क्रीन करा प्लीज. सर तुमच्या सगळ्यात खाली लॅपटॉपच्या लेफ्ट साइडला तुमच्या राईट साइडला ऑप्शन आहे सर.
तो कफ वाला ना? त्याच्या बाजूला सर. सचिन त्यांना सांग ना. फोर्थ वाला आहे ना ते?
हा सर, खाली तुमच्या याच्यामध्ये साऊंड वगैरे बार्स असतात ना खाली, आपण इंटरनेट कनेक्ट करतो साऊंड बार, त्याच्यावरती तुम्ही पीपीटी मध्ये सर एक याचा ऑप्शन येतोय सर. ऍक्च्युली मॅम मला इथनं दिसत नाही त्यांचा. योगेंद्र जी, आपको दिख रहा है क्या?
Yes, sir. Sir, you just need to click on this the bottom side where is the.
Hello, sir.
Yes.
Okay.
Yes.
Now it's done. Sorry for that.
It's okay, sir.
Okay, so I begin with introduction of my topic. India's population as per the 2011 census was 1.21 billion, second only to China in the world. India accounts for 2.4% of the world surface area, yet it supports more than 17.5% of the world population. This is despite the more than 60 years of family planning efforts since 1952. Because in 1952, India is the first country to launch the family planning program. According to United Nations projection, the figure could reach 1.6 billion by 2050. India's contribution to world population, you can see here that India contributing 17.5% of the total world population. Here you can see the census figure for last 4 decades, which indicates a percentile decline in growth rate of the population. You can see here that from 2019-21, sharp rises of the total growth rate, and again it deepened down from say 1990. These are the growth population in India. You can see here that in 1971, total population of India was 54.82 crores, which now in 2011, it is 121.02 crores. So decadal growth, we have definitely declined the decadal growth from 24.80% to 17.64 in 2011. Though India population has increased from 36 crore in 1951 to 121.01 crore in 2011, the country has witnessed significant decline in both fertility and mortality. In 2019, the birth rate for the country has declined to 19.7 from 20 in the year 2018, whereas the death rate has declined to 6 in the year 2019 from 6.2 in the year 2018. The infant mortality rate has decreased to 30 in the year 2019 from 32 in the year 2018. These are some of the indicators which are very much important as per the population growth is concerned. So 19.7 birth per thousand population was there in 2019, 6% death per 1,000 population, and 30 is the infant mortality rate in the year 2011. Indian government is concerned to control population growth many years back, and a population policy was introduced for this purpose. However, population stabilization still a long way off in India, unlike in China, where the population is expected to level off by 2030. Growth rate India-wise world. Here you can see that India has high growth rate. You can see here, I mean, so this graph is more than the China and is more than the world average also. So our growth rate is very, very high. Here you can see that Brazil, Indonesians, and other Bangladesh also has higher growth world average. But here you can say that our basic population is very high. If you say compare the growth rate as such, the doubling time of the India is much more less than the other populations because we have the larger population. As far as the India is concerned, India is categorized into developing world, developing country, and for any developing countries, there is a peculiarity of age pyramid. Here you can see that the age pyramid is shown, and most of the populations in our country is between the 15 years to 64 years of age group, which is said to be most reproductive age group, and that's why the momentum of population growth is very, very high as concerned in India. The growth of India's population since independence may be termed as rapid, as we have seen in previous graph that in 1951 there is a rapid rise of our population. So we can term it as a rapid, as the average annual population growth rate hovered around 2% per year for almost 4 decades. After 1981, the trend in the population growth rate was reversed. This is all thanks to because of our national population policy, along with the family planning programs, which advocates so many things that we see in the next slides also. The decline was slow during 1981 to 1991, but accelerated during the 1991 to 2000. The population growth rate of 2% per year doubles itself in a period of 35 years. India population more than double from 361 million to 763 million. There has been a slowdown in the population growth in the recent past, but the net addition to the population continued to increase. Why there is net addition to the population, I will discuss in later slides. From 2001 to 2011, the population growth rate declined from 1.97% to 1.64%. Population stabilization is a stage when the size of population remains unchanged. It is also called the stage of zero population. Country level population stabilization occurs when the birth plus in-migration equals death plus out-migrations. Thus, there is often a gap of few decades between the achieving the replacement level fertility, that is TFR 2.1. This is a very important indicator, TFR, that is 2 children per couple. And the population stabilization, there is always a lag time is there. As per national population policy, India has set itself the goal of achieving the larger goal of population stabilization by 2045. Population momentum refers to the tendency of the populations to continue growing beyond the time when the replacement fertility is achieved. I talked about the total fertility rate. If you achieve our TFR as 2.1, still there is a lack of a decade to achieve a total population stabilization. Because of the population momentum, there is a time lag between the achieving replacement fertility and achieving population stabilization. A delay in the onset of childbearing and increase in the interval between the births can decrease the impact of population momentum on the population growth. Here, we can quote an example of Kerala state, where we can see the clear picture of the increase in the first child bearing and the total interval between this or the spacing of the children. What are the factors which influence the population growth? The key indicator that is very much important for the demographers, like crude birth rate, total fertility rate, unmet need for family planning, contraceptive use, spacing between the birth, age at marriage, and first child. The current status, as per the latest available data, is as follows. As far as the National Family Health Survey 4, we said that we have decreased the unmet need of family planning from 12.9% to 9.4%. Women age 20 to 24 years married before the age of 18 years has substantial decrease from 26.8% to 23.3%. Total fertility rate has declined from 2.2% to 2%. This is uncommon in most of the state, which is there also TFR rate is very, very high, again more than 3. Healthy spacing between two childbirth, recommended period is 3 years, has increased definitely from 42.6% to 51.9%. Now, India has intensified the effort to stabilize population. India was the first country to have national program on family planning in 1952. National population policy was devised in the year 2000 with the immediate objective to address unmet need for contraception, healthcare infrastructure, health personnel, and to provide integrated service delivery for basic reproductive and child healthcare. Medium-term objective was to bring the TFR to replacement level by 2010 through vigorous implementation of intersectoral operational strategies. Long-term objective is to achieve stable population by 2045 at the level consistent with the requirement of sustainable economic growth, social development, and environmental protection. These three are very, very important as far as, again, population explosion is concerned. Meg Madam has also highlighted this point. National Commission on Population was constituted in the May 2000 to fulfill the objective of National Population Policy 2000. The objective of this commission are to review, monitor, and give directions for implementation of National Population Policy 2000. It aims to work in tandem with the goal outlined in the policy to promote intersectoral coordination in both the civil society planning and implementation and facilitate initiative to improve performance in demographically weaker state in the country. In April 2005, the National Commission on Population was reconstituted with a 40-member under the chairmanship Honorable Prime Minister and Vice Chairmanship of Minister of Health and Family Welfare, and Deputy Chairman of the Planning Commission. Now it is called as Niti Aayog. Government of India has been implementing the National Health Mission in the line with the policy framework for population stabilization as advised in the National Population Policy 2000. by helping to create a robust service delivery mechanism to address the unmet need for family planning. Government of India is also addressing social determinants of health, paramount among which are female literacy, women's empowerment, and age-at marriage. Stabilizing the population is an essential requirement for promoting sustainable development. Making reproductive healthcare accessible is the foundation for stabilizing population. In addition to various other parameters, population stabilization helps in strengthening human capital by focusing the health, inclusive of sexual and reproductive rights of the masses. Moreover, increased investment in family planning will help in mitigating the impact of population growth by helping people to achieve desired family size, avoid unintended and mistimed pregnancies. In this slide, you can see that there are perceptual decline in the population and related indicators over the 5 decades. Here you can see TFR is continuously decreasing trend from 2000 to 2016, same as CBR, that is crude birth rate. What is birth rate? Birth rate is a crude measure of fertility of population, and it is a crucial determinant of population growth. It gives number of live birth per 1,000 population in a given year and given region. Here again, you can see that it is continuously declining from 2010 to 2019. It's now 19.7. In 2019, the highest birth rate was observed in Bihar, that is 25.8, and the lowest was recorded or seen in Andaman and Nicobar, that is 11. Death rate is one of the simplest measure of mortality and is defined as the number of deaths per 1,000 population in given region and time period. Here you can also see that the decline is from 2010 to 2019 is now 6. And in 2019, Chhattisgarh has recorded highest death rate of 7.3, whereas lowest death rate has been recorded in New Delhi, that is 3.2. Infant mortality rate. This indicator is very much important as per the healthcare review system of any country is concerned, which is widely accepted as a good indicator of overall health scenario of the country or a region. Is defined as the infant death less than 1 year per 1,000 live birth in a given time period for a given region. Present level of IMR is 30 or less than that in 2022. We have reported in the highest in IMR is in 1971, that is 129, but now it is less than 30. This is the picture of TFR. It's also on decline trend from 1971 to 2016. Now it is in some state is 2.2, 2.3, or some state has more than 3 also. What is the national population policy says? National population policy 2000 says population policy center refers to policies intended to decrease the birth rate or the growth rate. In April 1979, India formed its first national population policy. It called for an increased legal minimum age of marriage for females from 15 to 18 years and for males 18 to 21 years. The policy was modified in 1977, which reiterated the importance of small family laws with compulsion and changed the program title to Family Welfare Program. National Health Policy approved by the Parliament in 1983 has the set long-term demographic goal of achieving a net reproductive death and NRR equals to 1. National population policy aims toward the free approach administrating, as Madam also been put light on this topic also. Previously, there is a different approach was there. Now it is a target-free approach. This policy also give importance to or deals in the women education, empowering women for improved health and nutrition, child survival and health, unmet need for family welfare services, healthcare for underserved population groups like urban slums, tribal community, hill area population displaced and migrant population, adolescent health and education, increased participation of men in Planned Parenthood and collaboration with NGOs. Now, something about Jansankhya Sthirata Kosh, National Commission for Population. In pursuance of the objective of National Population Policy, National Commission on Population was constituted in the May 2000 to review, monitor, give directions for the implementation of national population policy. It aimed at promoting intersectoral coordination, involves civil society in planning and implementation, facilitate initiative to improve performances in the demographically weaker state in the country. Within the realm of NCP, Jansankhya Shrita Kosh, also named as National Population Stabilization Fund, was established in the year 2003, is an autonomous society under the Ministry of Health and Family Welfare, was reconstituted in 2005 with addition of general body. This general body of JSK is headed by the new Minister of Health and Family Welfare, while Ministry of Women and Child Development, Rural Development, and Department of School Education and Literacy are represented by their secretariat. All state government are member of JSK. The governing body of JSK is chaired by the Secretary, Ministry of Health and Family Welfare, and it has eminent persons from the various fields as members, including social scientists, demographers, economists, scientists, as well as representatives of industry, trade, medical association, and NGOs. JSK aims and objectives to undertake activities, aims to achieve population stabilization by 2045, a level consistent with the need of sustainable economic growth, social development, and environmental protection, to promote, support, scheme, program, projects, initiative for the meeting and unmet need of contraceptions, reproductive and child health care, promote and support innovative ideas of the government, private and voluntary sectors. As the Gandhi madam has said, we can definitely run this vasectomy TV clips or the video clips in the in your own setup. This can one of the initiatives to facilitate the development of vigorous people empowerment in favor of the national efforts for population stabilization, to provide a window for channelizing contributions from individual trade organizations, other with the country and outside, in the furtherance of the national cause of population stabilization. Activities undertaken as are under Santushti scheme. Santushti scheme is a scheme for higher population rate, that like Bihar, Uttar Pradesh, Madhya Pradesh, Rajasthan, Jharkhand, Chhattisgarh, Odisha. Under this scheme, Jansankhya Shrita Kosh invited private sector gynecologists and vasectomy surgeons who are already working under National Health Mission scheme of Government of India to conduct sterilization operation in public-private partnership. Under this scheme, an accredited private nursing home or hospital working under NHM can sign an MOU with JSK. Upon signing this MOU, private hospitals, nursing homes shall be entitled for a top-up incentives for conducting 10 or more tubectomy or vasectomy cases in a month. All the cases covered under Santushti strategy are basically sterilization conducted under the NHM cases. JSK provide the top-up amount to promote support the private accredited facilities. These are some of the scheme that has been now running or existed. JSK is now closed autonomous body with effect from 8 to 2019, and now another scheme like Prerna scheme. Under Prerna scheme, couple who are broken the stereotype of early marriage that is happening in most of the tribal areas and repeated childbirth are recognized and awarded. This scheme also discontinued. However, this scheme is running under the banner of National Health Mission. Santushti scheme, as talked earlier, it is under the scheme, JSK invites private sector gynecologists, vasectomy surgeons to conduct sterilization operation under PPP mode. This scheme again discontinued, and now it is now superfluous in the wake of revise. Again, there is a revised compensation is formulated, and this scheme is run under the NHM, Ministry of Family Welfare. Now, National Health Plan is there for the reproductive health and family planning and infant health. This will be continued under RCH division of Ministry of Health and Family Welfare. In India, there are so many programs that is running parallel. Like we talked about the National Family Program, then we talked about the National Welfare Program, then there are different programs like CSSM program, RCH program, now NRHM program. Now these are the programs basically who are running for the betterment of maternal and child health, along with the other services like reproductive and sexual. Social franchising scheme. This is a very important scheme. It is a PPP scheme to enhance the uptake of family planning services by contracting with reputed agencies. It was sanctioned in Uttar Pradesh through SIFPSA. This is a state innovative family planning project authorities, which is running in Uttar Pradesh. This would henceforth be taken up under again NHM scheme. Some of the style features of this J scheme: tri-party, I mean, should need to be signed among the private health provider, state health society, and JSK. Accredited private hospital nursing homes who are under MOU with JSK, if conduct 10 tubectomy or vasectomy operation in a month, will entitled to get 500 per cases payable by GSK for organization activities, provision of payment of which compensation to client undergoing sterilization operation in private accredited facilities at the rate of 600 rupees for tubectomy and 1100 for vasectomy clients. All reputed NGOs, private accredited facility working in the state may also be eligible to participate in the scheme if they fulfill the requisite criteria for quality assurance. As per the decision of Government Board of JSK, a reputed NGO may utilize the infrastructure of PSCA and CSC. These are some packages that is being provided under this scheme for tubectomy and vasectomy. In order to help the push up the age of the marriage of the girl and space the birth of the children in the interest of the health of the young mother and infant, Jansankhya Sthirta Kosh launched Prerana, a responsible parenthood strategy in 7 focus states, namely Bihar, Uttar Pradesh, Madhya Pradesh, Chhattisgarh, Jharkhand, Odisha, and Rajasthan. This strategy recognizes and awards couples who have broken the stereotype of early marriages, early childbirth, repeated childbirth, and have helped change in mindset of the community. In order to become eligible for award under the scheme, the girls should have been married after the age of 19 years and give birth to first child after the at least 2 years of marriage. Couple will get an award of 10,000 rupees if it is a boy child, and if it is a girl child, it's at 12,000 rupees. If the birth of the second child takes place after the 3 years of the birth of the first child, and other parents voluntarily accept permanent method of family planning within 1 year of birth of the second child, the couple will get additional award of 5,000 rupees if it is a male child and 7,000 rupees if it is a female child. National plan, I have talked about this. Advocacy and under this scheme, there is scope of sustained ISC campaign, as said by your organization also. It's a very good move. Second, stall should be there in all the international trade fairs. Activities on and around the world of professionally should be observed. Now, what is the National Family Planning Program? India is the first country to launch National Family Program, and the key policy for this program is target-free approach, voluntary adoption of family planning methods based on the felt need of the community and children by choice and not by chance. Service level, with more emphasis on spacing method, assuring quality of services, expanding contraceptive choices. Key family planning initiatives and scheme, expansion of the basket of FP choices. We already talked about this. The choices are now increasing day by day. Augmenting the demand through ASHA scheme for family planning. ASHA is a really backbone of all the services that we are giving to the root level of the village. Promoting the quality of sterilization services, we are hiring the private practitioners, as well as we are training the medical officers to conduct the safe tubectomy as well as vasectomy. Promoting the quality ISD services and generating demand and awareness for family planning services. Addressing global commitment of family planning 2020. Now, I said there is contraceptive basket of choices under National Family Planning Program. There is temporary methods and the injectable method and permanent method also. Expansion that has been there nowadays, introduction of new contraceptive techniques. Some are the injectable forms, like in Antara program, the Saint Kurumani in Chaya program, Puration only pills, which is under the pilot project. Introduction of new devices, that is property ISD 375, is launched in the program 2012-13. Introduction of new method, postpartum ISD was introduced in the program 2010-11 and has provided postpartum women an effective spacing options. Augmenting the demand through ASHA scheme for family planning. This is a very important move because the contraception that is unmet need should be supplied at the doorstep. The home delivery of contraceptive, ensuring spacing at birth, pregnancy, testing kit. This is the part and parcel of the kit that is being supplied to ASHA worker. so that pregnancy availability of pregnant kits and early detection of the pregnancy will definitely will give rise to better look after the pregnancies or the say the future pregnancy of that particular woman. Promoting the quality of sterilization services. Sterilization. This is one of the important campaign nowadays. The compensation scheme also been increased, revised. The compensation package has been enhanced in most of the district, enhanced in 2014, and it is enhanced in 11 high risk TFR states, that is total fertility state, having more than 3 and above. Higher packages for postpartum sterilization and male sterilization. Higher packages for MPV, that is Mission Parivar Vikas, which is the Government of India initiative in 2016. In this district, the compensation for sterilization is increased. Generating demands and awareness for FP services, include counseling through RM and CH counselor. This is one of the program where the counselor really counsel about the different availability of family planning services. This is one of the important things. And this webinar we have just organized is very timely organized because we are going to celebrate this population day from July 11 to July 24. The population stabilization fortnight has helped to break this seasonal trend of sterilization services in northern state of India. It is being held in all the blocks, district, state of India since 2009. And the event is observed under 1 long period split into first 15 days from June 27 to July 10, and we call it as Dampati Samparka Pakhwada or mobilization fortnight. And second was from July 11 to July 24. We call it as Jansankhya Sthirata Pakhwada or population stabilization fortnight. Celebration of vasectomy fortnight, that is from 21st November to 4 December. The objective is to improve male participation in family planning. With this, I conclude my talk with the theme of World Population Day, that is a world of 8 billion towards a resilient future for all, hastening opportunities and ensuring rights and choices for all. Thank you very much for kind listening.
Yes, Asha madam.
Hello. Yes, yes. Can you hear me?
Yes, yes, ma'am.
Yeah. Thank you, Dr. Baker. You have come totally government scheme you have described like growth population index, birth rate, India and young India, and it requires more contraception, EFR, infant mortality rate, fertility trend, national family planning, JSK, promotion of Government of India for oral contraception, and given the services. And today we came to know that there is also vasectomy pakhwada. Hello?
Yes,
hello?
Yes,
hello?
Yes, ma'am. Yes, ma'am.
I'm not able to see anything. And
But you are audible. We can see you, ma'am.
Okay. Thank you for that. You have enlightened all government policy, and I'm really glad to see Dr. Mandakini Meg, to whom I work in Akola. Thank you. Thank you, sir.
Thank you.
Okay.
Thank you.
Thank you, sir, for sparing your time and for enlightening us with all the schemes. Thank you very much. Thank you. We are running shortage of time. Our last session is on legal issues in sterilization. And the chairpersons are Dr. Vaishali Datta, madam. She's president of Latur OBGY Society, practicing gynecology since last 20 years. I welcome you, madam. Next CV, please. Dr. Rupali Rathi, madam. She is the president of OBGY Society. I welcome both the madam. And our speaker, Dr. Ajay Manes sir, is not well. So his presentation will be covered by Dr. Rashmi Kahar, madam. Please show the CV of Dr. Ajay Manes sir. And I will read the CV of Dr. Rashmi.
Ma'am, I would like to thank you for accepting my invitation at the last minute, ma'am. Rashmi, ma'am.
I think, Sachin, you should start sharing the presentation, actually. I will introduce Dr. Ajay.
Hello.
Yes, ma'am. Yes, ma'am.
I think everyone knows Dr. Ajay Manes sir very well. And to proceed with, I want to invite and introduce Dr. Rashmi madam. And let the Ajay Manes sir CV will be there.
Yes, yes.
Hello,
Madam,
am I audible?
Yes,
Yes,
ma'am.
ma'am.
First of all, thank you, Dr. Priya Shinde and Dr. Monica, for giving me the opportunity to chair the session. It gives me immense pleasure to introduce a very famous gynecologist from Aurangabad, Dr. Ajay Mane sir. He is Joint Secretary of AMOX. He has also been Vice President elect Foxy 2024, and to his credit, he is consultant of medical legal cases. He is very helpful and very friendly person. I request Dr. Ajay Mane sir to deliver his speech.
Yeah.
But
Yeah. Lakshmikant madam will take this. Madam is the chairperson of AMOX High Risk Pregnancy Committee, and she was the organizing secretary AMOX in 2020.
Yes, thank you, Priya. Thank you, Priya.
But just one line, she is the, I think, ISOPAP joint secretary at present.
Thank you so much. Thank you, respected and very dear chairpersons, Dr. Vaishali Tai and Dr. Palidati madam, for the kindest words. Heartiest congratulations to dear friends Monica, Komal Chauhan and Priya for a very thoughtful and successful organization of this conclave on occasion of Population Control Day. My humble regards and respect to respected Dr. Pardeshi sir for giving me this opportunity, and also to respected Dr. Ajay Mane sir. It's a great honor to be able to be here and present Dr. Mane's presentation on medical legal aspects of sterilization. My respects and regards to respected Dr. Mandakini Meg madam, Dr. Sneha Bihar madam, Dr. Vandana Gandhi madam, all the co-speaker, Dr. Shobha Gudi madam, and the chairpersons. So in next 10 to 12 minutes, I will be taking you through the journey of medical legal aspects and documentation of sterilization. Start the sharing, please. Yeah, next, please. Yeah, so let me just introduce say a one word before that all the slides and this presentation has been very meticulously curated by Dr. Ajay Mane sir. Each word holds a high degree of medical legal importance, and the slides are excellent and amazing. It's a great honor on my part to be able to present this presentation to all of you. So when it comes to documentation before sterilization, the first and the most important thing is the list of the documents we will be needing. And it will be an OPD case paper and indoor case paper, registration in R3 register with yearly number, written and informed consent, OT register, certificate of sterilization, and a follow-up schedule. Next, please. So when we talk about the OPD case paper and indoor case paper, yeah, next, please.
Yes, ma'am. So there is something problem.
Is it visible?
No, the slides are not moving.
Not moving.
Ma'am, is it visible now?
No.
I think you have to download now. It is in the mail. You download this.
No, ma'am. It is already downloaded by my side.
But it is seen in the mail.
Yes, it's visible.
Now it's visible.
Yeah.
Yes.
Next.
So when it comes to OPD case paper and indoor case paper, as we all know, the OPD case paper should have a routine OPD case paper with identity proof. And the indoor case paper should have all the details of the operative procedure with consent, detailed consent, OT procedure, notes, follow-up, and a discharge card. So when it comes to the vasectomy, what is the eligibility criteria for vasectomy clients? So self-declaration by the client will be the basis for compiling this information. Client should be at least 22 years old and should be below the age of 60 years. He should be able married. The couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. Clients or their spouses must not have undergone sterilization in the past, and it's of course not applicable in the cases of failure of previous sterilization. the client must be in a sound state of mind so as to understand the full implications of sterilization. Mentally ill clients must be certified by a psychiatrist, and a statement should be given by the legal guardian or the spouse regarding the soundness of the client's state of mind. Next, please. Any trained and empaneled MBBS doctor can provide vasectomy services in government institutions, and accredited private NGO facilities also can. The state should maintain a district-wise list of doctors empaneled for performing sterilization operations in government institutions and accredited private or NGO facilities. The list of such doctors should be updated quarterly. When talking about the informed written consent for vasectomy, we should understand that the provider must ensure that the client has made an informed and voluntary decision for vasectomy before signing the consent form. Clients must be encouraged to ask questions to clarify their doubts, if any. Clients must be told that they have the option of deciding against the procedure at any time without being denied their rights to other reproductive health services. Documentation of informed consent in India, the client's signature or putting his thumb impression on an informed consent form is the legal authorization for the vasectomy procedure to be performed. Though the consent of spouse is not a prerequisite, ideally the spouse should also be concerned about the procedure. Next, please.
Yugendraji, please, next slide. Thank you.
And of course, the clients must be beforehand told that a reversal of this surgery is possible, but the reversal involves, of course, a complex surgery and its success cannot be guaranteed. So when a female undergoes sterilization, what is the eligibility criteria? And this will also depend upon the self-declaration by the client, and no eligible client should be denied female sterilization services. She should ever be married. Female client should be above the age of 22 years. She should be below the age of 49 years. The couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. Clients or their spouses or partners must not have undergone sterilization in the past, not applicable, of course, in cases of failure of previous sterilization, and clients must be in a sound state of mind so as to understand the full implications of sterilization. Mentally ill clients must be certified by a psychiatrist, and a statement should be given by the legal guardian or the spouse regarding the soundness of the client's state of mind. A relevant medical history, physical examination, and laboratory investigations need to be completed to ascertain eligibility for surgery. Next, please. While talking about female sterilization, there has a very important role. There is a very important role of general counseling. It should be done for all the clients seeking for family planning services. The main aim of general counseling is to provide informed choice to enable them to take a decision regarding the type of contraceptive method to be used. However, in all cases, method-specific counseling on the chosen method must also be given. It is unlikely event for any complication or failure or death. For that matter, there is a redressal mechanism available in the form of an indemnity coverage, and no separate form for this indemnity is required. Next, please. Method-specific counseling is during counseling for sterilization. Use of simplified schematic diagrams can be helpful. We have just seen our prior topic by Dr. Vandana Gandhi, madam, that the video demonstration was of utmost use. The following steps should be ensured before the client signs the consent form. Like the client have been counseled wherever required in the language they understand. Clients have been informed of all the available methods of family planning and procedure. Clients have been made to understand what may happen before, during, and after the surgery, its side effects and potential complications. And clients have made an informed decision for sterilization voluntarily. Next, please. of the sterilization procedure should be explained to the client. It is a permanent procedure for preventing future pregnancies. It is a surgical procedure that has a possibility of complications, including failure, requiring further management. It does not affect sexual pleasure, ability, or performance, and will not affect the client's strength or ability to perform normal day-to-day functions. Sterilization does not protect against reproductive tract infections, sexually transmitted diseases, HIV, or AIDS. And a reversal of the surgery is possible, but the reversal involves major surgery, and the success of which can't be guaranteed. Next, please. It is very important to note down that the consent of the partner is not required for sterilization. However, the partner should be encouraged to come for counseling. While talking about a female who is HIV positive or has AIDS, the sterilization concerns are as such, though no woman should be denied female sterilization based on their HIV status. Women who are living with HIV, have AIDS, or on antiretroviral therapy can safely undergo female sterilization. The procedure is done as in other clients, ensuring universal precautions. We can counsel these women to use barrier contraceptions in addition to undergo female sterilization. Use consistently and correctly the barrier contraceptions help prevent transmission of HIV and other sexually transmitted diseases. No woman should be coerced or pressurized into having sterilization, and of course that also includes women with HIV. Documentation of the informed consent consists of the client's signature or putting her thumb impression on an informed consent form, and this is the legal authorization for the sterilization procedure to be performed. The client must always sign or put her thumb impression on the consent form. In case of thumb impression, a signature of a witness, any person, witnesses will be any person not associated with the service facility and chosen by the client is a must. Consent for sterilization should not be obtained when physical or emotional factors may compromise a client's ability to make a carefully considered decision about contraception. Documenting denial of sterilization. When a client who is unfit for sterilization is consented and offered, we can offer another method of contraception. The reason of this denial, the reason for this denial of sterilization must also be documented in the prescribed consent form. When a client evaluation indicates sterilization to be unsuitable for her either on medical or non-medical reasons, the client record should specify the reasons. For example, the client has a condition that precludes surgery. The client may be uncertain about her choice, etc. The action taken by the provider should also be described, like was she referred, was she offered a treatment for her medical condition, was she offered another method of contraception. This record should be kept at the service facility where the client was evaluated and the sterilization found unsuitable for her. So this is the column, and it shows about the details about the denial. There are 4 types: A, C, D, and S. The A is the accept, C is the caution, D is the delay, and S are the special conditions. When there is no medical reason to deny sterilization to a person with this condition is the category A. Caution is the procedure normally conducted in a routine setting, but with extra preparation and precautions. The procedure is said to be delayed until the condition is evaluated or corrected, like her medical condition has to be corrected, hemoglobin status has to be corrected. Alternative, the temporary methods of contraception can be provided during this duration. And there are some special conditions for denial, like the procedure should be performed, where the procedure has to be performed by an experienced surgeon and staff in a setting where equipment for providing general anesthesia and other backup medical support is available. To meet these conditions, the capacity to decide on the most appropriate anesthesia regimen also needed. Alternative temporary methods of contraception should be provided if referral is required or if there is otherwise an delay. We have to go and get detailed notes of anesthetist also. the anesthesia or the analgesia provided, what was the type, was it local or it was general, whether there was intubation or no intubation, any other specific factor, the time of anesthesia, the drugs used, the dosage given, the route of administration, and of course, it has to be completed with the signature of the anesthetist in case of regional or general anesthesia. The follow-up counseling holds its own importance. The information provided after the procedure is reinforced. Service providers need to listen attentively and be prepared to answer questions the client may have and address the problems she has experienced after undergoing the procedure. This helps the client cope with common problems or side effects. Advise clients to return to the facility if there is any missed period or suspected pregnancy or bleeding PV within 2 weeks to rule out pregnancy. So this is about the registration in R3 register with the yearly number, and the columns of importance are yearly number, monthly number of the patient, patient's name and details, temporary address, permanent address, vasectomy or tubectomy done, method of operation, rural or urban setting, age of the wife, age of the husband, the religion, caste, with the number of offspring she has, youngest child's age, education, family income, date of operation, hospital address, providers, that is doctor's name and address, promoter's name, promoter's designation, was there any history of previously used contraception, and remarks. Next, please. Next, please. Yeah, the OT register should also consist of the yearly number, monthly number, date, patient's name, age, address, type of anesthesia given, operation performed, specifically whether it was PNC, TL or interval TL, name of the anesthesiologist, name of the surgeon, assistant, and the remark. These are the forms we are all aware, very much aware with this form. This is the certificate of sterilization. Next, please. This is the another format of sterilization certificate. Next, please. And there has to be a specifically follow-up schedule, like in a male sterilization case, the patient has to return to follow-up after 48 hours, 7 days, and 3 months. A female should report to the facility if there is any bleeding or spotting in 2 weeks. Otherwise, she can come on the next menses for the certification. This is the Government of Maharashtra booklet. Next, please. Yes, and the comprehensive booklet is presented by the Government of Maharashtra. This is the Margadarshika. We can keep all these books and the general guidelines in our OPD for patient information. And we can also use this follow-up chart, which includes what is the time of follow-up, what was the condition. Next, please. So we are all aware of, there are rewards of sterilization also. We can counsel and inform the patient that female sterilization by any method. If she's below poverty line, she will be getting ₹600, above PL, ₹250, and a facilitator for female will get ₹150, and in case of male sterilization, it is $1,451, and the facilitator will get ₹200. These are the rewards for sterilization. So if there is any mishap, if there is failure of operation, the surgeon has to reoperate free at the free cost, and also do the MTP, and she will get a compensation of ₹30,000. In case of a complication, 25,000 extra are given for hospital expenditure. In case of a day, 2 lakh is the compensation. The consent form duly signed itself in the form of insurance by government insurance agency. And thank you very much. Thank you, Dr. Monica, Dr. Komal Chauhan, Dr. Priya Shinde, and Amox. Thank you very much for the opportunity.
It was a very crisp and clear talk. Dr. Rupali Rathi madam is there?
Yeah, I am.
Yes,
Good evening. Thank you, organizers, for giving me this opportunity. A very good talk, actually, very nicely explained by Rashmi ma'am. Document list, especially the eligibility criteria for vasectomy and vasectomy providers, importance of informed consent for vasectomy and female sterilization, importance of counseling, especially very nicely explained. It's actually any sterilization process is just counseling and counseling. Importance of the procedure and reversal was very well explained, ma'am. And documenting denial of sterilization is one thing which is very important, I thought. And record keeping, which is the utmost important point, which was highlighted in this lecture. Maintaining R3 and OT register is very important according to this, and follow up very nicely explained. Thank you so much for giving me this opportunity. Thank you, everyone.
Let me inform all of you that it is such a meticulously and very well created talk, and each word and a sentence is of medical legal importance. Actually, it's really a very good talk, and it's a great honor to be able to present Dr. Ajay Mane's talk here on this platform.
Rashmi, can I ask one question?
Yeah, Dr. Pardeshi sir is also there. If there are some.
No, I missed one because I'd gone out. Is there any mention of recanalization? Recanalization in tubectomy operations? No.
What madam?
There are cases in the past when they want to have a recanalization because all the offspring or something, there are death or what. So have you mentioned about it? Just I wanted to ask.
Yes. It was mentioned actually.
So she has mentioned, but madam is asking whether it is mentioned in government guidelines.
Okay.
No, madam, there is no.
I had gone out, no? So thank you very much. Yeah.
Thank you, Dr. Rashmi. Actually, last moment she has taken so nicely and elaborated all the points. Just I want to highlight one point. In case where government has also mentioned in their literature that 0.3 to 7% failure rate is there, but it is only for tubectomy. And if you are negligent, then it is not covered. In one case in Karimnagar, I think Dr. Shobha Gudi ma'am knows. One case, in short, I wish to tell you, 2 daughters, 1 son, and they had been to PHC and they did tubectomy. And after 1 hour, patient was serious and they had to transport to another hospital. And there they opened sigmoid colon was cut. They had to operate. After that, she gave birth to 1 child. Again, this 4th child. And they wanted that this is a tubectomy failure and all that. That court has given compensation 1.5 lakhs. Court told 0.3 to 0.7% is there. That is not for that, but that is for the procedure, sigmoid colon cut, and due to the physical and mental agony. So remember it very well. Other negligence will not be tolerable in the law. And next thing important is, now in one case, one doctor has done MTP and immediately after 15 days, another doctor has done tubectomy. And after that, patient pregnant gave birth. What's the fault? Then after that, that revealed that the MTP was incomplete, the sac was there, they had to, but remember is that after MTP or even before any operation, if patient is giving history of MTP, do USG. Correct. That is very important. Even if we are telling it's not in the MTP law, but before MTP also, you do sonography because sonography is now available. Now, many people, they are asking whether to do MTP with TL. MTP with tubectomy is allowed in both. Only thing, Dr. Shobha Gudi ma'am is expert in that. That first trimester, you can do. Second trimester also you can do. Only thing is that laparoscopic sterilization, government is telling as far as avoided in second trimester because of occlusion of tubes, injury to the tubes and slipping of the rings. These are there are many, this legal hassle we have to be take care of. Thank you so much. Rashmi has really narrated very nicely.
Can I share one incident of Aurangabad?
Yes.
Interesting, yeah. When I was, in the post that time, we got a court order that one of the medical officer who has performed tubectomy, the tubectomy failed 3 times. The case was from Aurangabad, and that poor medical officer who is on the government salary, that time salary was also 4,000-5,000, to pay to the couple around, I think, 2.5 lakh rupees as is personal. So from that onwards, all the government people started saying that it is not our fault. We did it with all utmost care and all, and how they are punishing us by giving the personal, punishment. So that was the case I just wanted to mention. So in that case, you have to be very, very careful when you, of course, we all are doing with a lot of utmost care, like eating, even if your Phillips ring in the laparoscopy is slipped, that time you have to supposed to mention all these things are there to avoid the medical legal compensation and cases. So I just wanted to share that.
And we are advising for MTP and tubectomy. It has been there, you can do, but we are telling take separate consent of MTP and separate consent of tubectomy, because if any problem arises in MTP, it will unnecessarily go to tubectomy. This is the main, and if any problem after that, but the label is MTP with tubectomy. So the inquiry, all we have to face. So better to take separate incision.
Yes.
After separate consent.
Yes, separate. It has to be, MTP has to be according to the MTP.
MTP Act, they have given consent form, so that also has to be filled. And the tubectomy also, we have a separate consent form, so that also has to be filled.
Now one in chat box, one question is really a very nice question. She asked, was 6 gram hemoglobin is a ectopic operated, and the patient's relative, they are telling no tubectomy do. And Vandana Gandhi, she has answered very nicely, better to avoid, as tubectomy is a national program and it's a complication now we are dealing. So in the complications, we shouldn't do tubectomy. She is right.
Yes, same with the rupture of uterus.
Yes.
Because
Rupture uterus or any complicated.
I think Rashmi's mother and we were the colleague, and we did so many ruptures, and we remember doing the tubectomy but not mentioning that also. I'm sorry on this platform telling,
correct,
but we had to do it because in the interest of the life of the patient.
Correct.
Our mother and we were doing it all the time, alternate rupture uterus.
Correct. Fortunately, Mandakini ma'am, today that situation is very rare. Correct. And we must give the message today, because today litigation is very, very high, not
Very,
like
very
earlier.
high.
So
fact,
today we should not do that. We should never do a procedure without documenting. Better to avoid, because also the LARC methods give a very good option today. So if we are, wanting to give her an injectable immediately, or we can place an IUCD after some time, that may be better rather than doing the tubectomy. And we can always tell the man to go for vasectomy. That is better.
This postpartum IUCD program, which is government is promoting, we should go for that also, because that is also a very good alternative.
Correct.
So when we were in Mumbai, so one case happened. So we tackled it. That's why nowadays, if this could happen, so it was. So we did a MTP, and after that, we used to do all vaginal tubectomies. So they were called. So that unit, and they did the vaginal tubectomy, sent patient home. And after 10 days, patient collapsed. And then after that, come out, it was an ectopic, because in vaginal tubectomy only the salpinge and fimbria and all those, it was corneal, it may be of corneal ectopic that missed.
In expert hands also, vaginal tubectomy is a blind procedure.
Exactly. But that's why now
just came and went. I think vaginal tubectomy came and went, and I don't think it should be.
Now we are not doing. But this is the scenario. We should be take care of that all.
But at one time there was huge camps in Akola Women Hospital, Amravati, where Dr. Purandare, I assisted him so many times. I think Rashmi remembers that. They used to take a very good bite in the vagina. So I was a young person.
Can stop the transmission, Yogendra.
Yeah. So every time we used to tell them, sir, bagabar khub mota bite getla. Once I tried to tell B.M. Purandare, he saw in a very, very manner. He said, "नाही sir, खूप मोठा दिसला, आमच्या इथला एनिमा बरोबर दिला जात नाही." I was trying to tell him in our own hospital, अशा निकतेला माहिती आहे. He took a very big bite. And I said 100% after that there was an intestine had gone. So, this kind of things happen. Just wanted to share.
I have one question. Dr. Mane is not there, but
Yes,
nowadays instead of Fallope rings for laparoscopic sterilization, can we use the cautery method? Cut the tubes and cauterize the ends, which if it is available for vasectomy, is it indicated and not discouraged? I mean, if it is supported legally, can we do the cauterization method of tubes? It is very fast than Fallope ring.
No, cauterization is not a recommended method. It has led to higher incidence of tuboperitoneal fistulas and failures and ectopic pregnancy. Cauterization
Government guidelines they dile na, the government guidelines they dile. We have to be in the ambit of the government guidelines. It is only recommending the Fallope rings, not the cautery.
Correct.
Yes. The anatomy of fallopian tube is different than other structures, and it is not suitable for doing.
Recently, one of the laparoscopic surgeon did it because what she convinced me that we are doing TLH with bipolar resection and cutting it, the pedicles. Similarly, we can do with the tubes if there is enough space cutting and lateral coagulation. So, but if it is not legally,
it is not legal. It is not supported by guideline. And whenever we practice family planning, it is better to go with the state, with the government, and whatever is there in the book, because I think whatever else we do will not be supported. Not be supported. So it is better not to deviate from that. It should be practiced like religion and like mantras. Should not be deviated.
Very well said, ma'am.
So then what happens with cautery is that there is more tissue damage, and whatever methods we practice, standard methods of tubectomy, we keep the operation potentially reversible. We remove smaller segment, we do less damage like that, and at the same time ensure that there is no failure. Both these principles cannot be fulfilled when you do a cautery. So it is not correct. And also using electrocautery will have its own disadvantages, and we cannot train people to use cautery. It's a different training when electrocautery is being used. So there are so much concern against it, and I would recommend people not, unless there is a complication for which extra things have to be used. Sometimes the tubes are very vascular, or there is an injury into the mesosalpinx, there is bleeding from the mesosalpingeal vein, something happens, there are adhesions, then we use, but we report it completely, we document it. This was the problem and this is what we have done. So I think then we are safe and the patient is safe. Yeah.
Thank you, ma'am.
Ma'am, if we consider whatever is written in the sterilization guidelines and not fall prey to what the patient wants. If the HB is low, we should give her hematinics, wait till the HB rises and only then do. Because most of us fall into prey and they want blood transfusion and then tubal ligation to be done.
Yeah.
Guideline specifically mentions that TL could be done after menses as an interval tubal ligation up to day 7 or day 8, ma'am. So if the patient comes in the mid-interval period, then we should advise them to come after menses and not do it at the same time, in order to avoid the risk of accidental pregnancy at the time of ovulation.
Yeah, correct.
She could be pregnant when they are doing a TL on day 20 or 22, and then it comes to TL failure. So if we follow the guidelines which have been given word to word, then we will not come into litigation.
Correct, very correct.
If there is a temptation, because it is open, we can do, that temptation should be avoided.
There is that ACDS criteria Rashmi has told, I think so. No? ACDS criteria, we have to follow that for women with complicated cases, etc. And there is a very correct recommendation of delaying whenever the morbidity is more, like severe anemia. So A is accept, D is delay, and C is caution, and S is special. So we should follow the ACDS criteria, just like MEC criteria for contraception, ACDS criteria for sterilization. We should follow that. Yeah.
Madam Shobha, Madam, it was a great thing to have you on Amox's platform today. Please come again, ma'am, whenever we require you.
We had public forum with Shobha Gudi madam in September, and that was a huge hit. And I suggested Monica madam, Shobha Gudi should be our part today's session.
Thank you, Priya. Very kind. Thank you so much. And
Slides.
I must say that Dr. Pardesi has been, very encouraging for me from the very beginning.
Yeah.
And I still
Very
remember.
encouraging and a very constant source of inspiration and great support.
Yeah, he supports people who want to work for Foxy very much. And Meg madam, if the first time around when I contested for this committee, I lost. And then he told me that if you are really sure about this committee, then you must contest again. And rightly, I waited for 3 years and I again went for the same committee. So,
You remember mini program we done for the, that I have we done so many programs with Dr. Pardesi.
Correct.
So I think by means of such celebration of such days like Population Day, there's a brainstorming event with all the stalwarts, and also we get benefited with all the updates. Thank you everyone, and for the formal vote of thanks, I would like to invite Dr. Komal madam.
Dr. Pardesi, मला तुमची परमिशन पाहिजे जरा.
बोला ना.
मला बोलू?
हाँ बोला ना.
बोला. ओके.
मी जरा वाटच पाहत होते जरा.
तुम्ही सर्वात सिनियर आहे.
नाही मला काहीतरी वेगळं बोलायचं म्हणून.
बोला ना.
So all the esteemed faculty and everybody, I just want to, with the permission of the chair, I want to just request all of you that I am contesting for the post of President Foxy, and I'm very sure with all the support of you, Dr. Pardesi, and everyone, I will be able to deliver the goods once, like ICOG, I am elected. So thank you very much for your kind, support, and looking forward for your blessings also. Thank you very much.
All the best, ma'am.
All the best, ma'am.
All the best.
All the best. Good wishes.
I wish you all the best in all your endeavors, ma'am.
Thank you very much. Thank you for permitting me.
Madam, you need not to take permission. You are senior in all this audience. And
chair चा मान असतो ना म्हणून. चल हां. Vote of thanks.
Komal, are you there?
You continue, Priya. You can continue.
Yeah.
Monica ma'am?
I would officially like to propose the vote of thanks for this webinar. I'm extremely thankful to Dr. Pardesi sir, Dr. Shobha Gudi madam, Dr. Vijay Chiransar madam, and Dr. Neha Buyar madam, who have consented to be the for this evening. I would also like to extend my thanks to all esteemed faculties, that include Dr. Bhaitar ma'am, Dr. Rashmi Kahar, Dr. Mandakini Meg ma'am, and Dr. Shobha Gudi madam, and Dr. Vandana Gandhi ma'am, all the societies and the chairpersons for this session. Extremely thankful for your valuable time and valuable input. Definitely benefit our delegates. Very important thanks to Dr. Priya for conducting this program beautifully, and to the Walter Bushner representatives, Mr. Sachin and Mr. Yogendra. Thank you so much.
Thank you, ma'am. Thank you very much.
Last but not the least, the program would not be possible if Pardesi sir would not have granted the permission. So, sir, extremely thankful and a heartfelt thanks to be the backbone for PAC committee. Thank you so much.
Thank you, ma'am, for providing this such a scientific opportunity to participate for the technical support. And Walter Bushnell is always ready to provide such kind of scientific case, ma'am. Thank you very much.
Thank you so much.
So with the thanks note from the Walter Bushnell, I Sachin Amte, Regional Sales Manager from Pune region, rest of Maharashtra. So extremely thanks to Monica madam, Priya Shinde madam for all these platform, and we would like to more associationship with this all these faculties. Thanks Amox, and with the prior permission of Monica ma'am, can we stop this recording and webinar?
Yeah, you can stop the recording.
Okay, ma'am. Thank you, ma'am.
Thank you, everyone.
Thank you, and a very good bye.
Thank you, everyone. Thank
See
you.
you soon.
Thank you, ma'am. Thank you so much, ma'am.
Bye, ma'am.
Bye, Priya, Vaishalitai. Bye.
Thank you. Bye, bye, bye.
Bye.
Bye, Monica.
Bye, ma'am.
Bye.